Hello dreamers. So in this video we are going to discuss psychiatry rapidly. So we'll cover some of the important topics which are important for your exams. So let us begin. So let's talk about the basics of psychiatry. The term psychiatry is derived from two words, psyche, which means mind, and iatry means healing or cure. So it's a branch of medicine which deals with problems of the mind and its treatment. The term psychiatry was coined by a German physician, Johann Christian Riehl. Now, how do we approach a patient with psychiatric symptoms? So first is we take a detailed history. Now, history is not just taken from the patient, but it is also important to take history from the informant accompanying the patients. Because many a times, as we see, that patient may not be able to give the history entirely or correctly. So it is important to include the informant in the history taking. And then subsequently, we do the examination. Again, very important part. We'll talk about the examination of a psychiatric patient. Now, investigations have a very limited role. And many times we do investigations to rule out other disorders. For example, if someone has a head injury, we may do a brain scan to see which area of the brain is affected. Or if someone has developed encephalitis, we may do blood counts or CSF examination to see the infection. And ultimately, whatever we are doing, the aim is to reach to a diagnosis so that we can manage the patient. Now, when we talk about the informant, we check the reliability of the informant. How reliable is the information provided by the informant? So, there are various headings under which we check the reliability. There are 5 C's and 1 I. So, the first C is consistency. The information provided by the informant, whether it is consistent, that is, it is same in each interview, or even during one interview, whether the information is same throughout or is it changing. So suppose a patient's informant is giving one type of history at one time and in another interview, he is changing the details. So we'll say that the informant is not giving a consistent history. Second is chronological. Whether the information provided by the informant is in a chronological manner. That means, let us say, if the symptoms of the patient started 2 months back, is the informant able to tell us the symptoms which developed initially and subsequently how they progressed? So this is chronologicity. The next is coherence. The information provided, is it logically connected? Are we able to understand the information? Or sometimes if the information could not be connected logically, then we say it is incoherent. Then next is closeness with the patient. Now again, it is important, as suppose a patient comes to us since 1 month history and the parents are, with the patient. But the patient during these 2 months or during this 1 month was staying with his friend in the hostel. So it is important that during the development of these symptoms, was the patient staying with the informants or not, so that we can see how well the history could be derived. Then fifth is again important, concern for the patient. Is there a genuine concern for the patient? Are the informants really concerned for the patient? And this is especially important in medico-legal cases because there might be some vested interest of the informant. So they may give a false history. And yes, subsequently, lastly, it also depends the reliability on the intellectual or the observational ability of the informant. If the intellectual or observational ability is low, then again, reliability will be questionable. So these are some of the aspects of reliability. Now let us start with the examination. Now whenever a patient with psychiatric symptom comes, of course, we'll do a general physical examination, systemic examination. But one specific examination which we do in all the patients of psychiatric illness to see the signs and symptoms of psychiatry is known as mental status examination. Again, very important. Now, the first aspect of MSC is general appearance and behavior. So again, the examination starts, as soon as the patient enters the room. So the first thing is general appearance and behavior, and this we notice the dressing. Now dressing is generally with respect to the weather condition. Now suppose it's a very hot and humid temperature outside, let us say 40 degree Celsius outside, you're sitting in your OPD and a person comes wearing so many layers of clothes like jacket, sweater, muffler, cap. Now, is it appropriate dressing with respect to the weather? No. It seems to be very inappropriate dressing. So again, such inappropriate dressing may suggest that person may be suffering from certain severe illnesses like schizophrenia. Again, this is just giving us some hints. It's not that if we just see the patient we'll make a diagnosis, but these things will help us in making or establishing a diagnosis. Now, second in the general appearance and behavior is we see the grooming. How well the person has groomed or how well he's maintained his self-care. Again, let us say if a patient comes in the OPD and he's uncombed hair, there is dirt all over the body, very foul smell is coming from the body as if he has not taken shower for 10-15 days. So again, poor grooming may suggest that patient may be suffering from some psychotic illness like let us say schizophrenia. Now, second aspect of the MSc is the speech. Now, in speech, we see the rate of speech. Rate of speech is basically number of words a person speaks in a minute. Now, normally when we talk to each other, the rate of speech is as such that we can understand each other. But sometimes there may be certain conditions in which the rate of speech is very high. Person is speaking very, very fast. For example, the patient may speak like this. My name is Dr. Ankit Gul, I'm a psychiatrist in Delhi. I like playing cricket. So patient is speaking very, very fast. So the rate of speech may increase in disorders like mania. While there may be some patients in which the rate of speech may be decreased. For example, patient may speak like this. My name is Dr. Ankit Goyal. So patient is taking a lot of time. Patient may take a lot of pauses and may speak just few words in a minute. So decrease rate of speech may be seen in disorders like depression. Now let us come to a very important aspect of the MSc, that is mood and affect. Both mood and affect are related with the emotions of the patient, but there is some important differences. So let us understand with the help of this table. Now mood is persistent and pervasive emotional state. It's an emotional state which is persistent. Persistent means that it is present most of the time. So patient says, sir, I'm feeling sad most of the time, whether it is morning, afternoon or evening. And pervasive. Pervasive means most of the places. So person says that whether I'm at my office, whether I'm at my home, whether I'm in a kitty party, the female says that, I feel sad. So this sadness is persistent and pervasive. So this is how we define mood. While affect is the expression of emotions. So, you will see normally also, if any of your family member is sitting and they've not spoken anything, but you may go and ask, why are you appearing so sad? So that means our emotions are also expressed on our face, in our body language. So this is something which we observe as a therapist. So affect is observed by the therapist. So mood is something which is internal. This is something which the patient will tell me. I'll ask the patient. While affect is something which is external. We will observe the affect. Now, mood is something which is a long-term phenomena. So when we have to check the mood, we'll ask the patient, how has been your moods in the past few days or weeks or months? So mood is something which is longitudinal. While affect is something which is cross-sectional. So we will tell the affect when we see the patient. So at that very moment, we can tell the affect of the patient. So I can tell the mood of the patient maybe 2 weeks back by asking him. While affect, I can only tell when I'm observing the patient. So these are some important differences between mood and affect. Of course, we use this term interchangeably. When we'll talk about mood disorders, we'll also call them affective disorders. Now, there are certain structures which are related with the emotions. Now, first is where the emotions are generated. The emotions are generated in the limbic system. And which area of the brain regulates emotions? It is the frontal lobe. So suppose you're watching a movie and it's a very sad scene and you may appear sad or you may start crying. So which area of the brain regulates your emotion? It is the frontal lobe. Now let's talk about certain abnormalities of affect. So affect, generally when we see the affect or the quality of the affect, whatever predominant emotional state is there in the, in the patient, we will tell that is the affect. But there are certain important abnormalities which we see. First is what is known as flat affect or blunt affect. So what is flat affect? It is when the emotion is not changing. Now, you can remember it like this, flat affect, when you see the ECG of a normal person, there will be, waves, ups and downs will be there. While what is the ECG of a dead person? It is a flat line. So here in flat affect, as if the emotions are dead. So for example, we are talking to a patient. Let us say I am discussing something sad. Let us say 1 year back, any of his family member died in a car accident, but the patient is looking like this. There is no change in the emotion. Now let us say I am talking about something good. Let us say 6 months back, he became a father and the patient was promoted. I am talking about something good event in his life, but again, the patient is looking like this. There is no change in the affect. So this is flat affect. The emotions are not changing. And one important condition in which you may find flat affect is schizophrenia. Another important abnormality is labile affect. Now you can understand it like this. It is just the opposite. Now, so here what is happening? There is rapid and abrupt changes in emotions. Now here, even without any external stimulus, there is rapid change in the emotions. So suppose I am talking to a patient, I have not cracked any joke, the patient has not cracked any joke, nothing funny has happened around. But the patient starts laughing, and within few seconds the patient starts crying, then again starts laughing. So there is rapid and abrupt changes in the emotion without any reason. This is what is known as labile affect or lability. Now, again, two important conditions in which you may find this labile affect. One is mania and the other is organic mental disorders. Now also let's talk about some important other terms related with emotion. One is anhedonia. Now what is anhedonia? Anhedonia is decreased interest in pleasurable activities. So a person says that activities which earlier I used to enjoy, I don't enjoy them anymore. For example, a 30-year-old female says, sir, since the past 2 months, I don't feel like, I don't enjoy going to parties, I don't enjoy going to my relatives or watching a movie. So there is a decreased interest in previously pleasurable activities. So this is anhedonia. So again, anhedonia can be seen in conditions like depression. It can also be seen in conditions like schizophrenia. In fact, it is one of the negative symptoms of schizophrenia. Now, another interesting term is alexithymia. What is alexithymia? It is basically inability to express or understand emotions. So person is not able to express their emotions or understand the emotions of theirs or even others. This is alexithymia. Now let's talk about the next component of the MSc, a very important component, that is the thought. So let us try to understand what kind of problems can occur in the thinking of the person. Now the disorders of thought we have divided into 4 domains. First is the flow or stream. So the thoughts flow in our mind. So if you just sit silently, you may observe that the thoughts are flowing. So when there is problems in the flow of the thought, we say there is problem in the flow or stream. Second is content. So the content is abnormal. So what the person is thinking, that is abnormal. Then next is form. Form means organization or structure. The organization of the thought is affected in disorders of form. And lastly, we'll talk about possession. Possession means normally all of us know any thought which comes to our mind, we possess that thought. But sometimes patient may not experience that same thing. Patient may feel that this thought is not my thought or it is influenced by someone else. So then we say there is problem of possession. So let us discuss some of the important abnormalities in each of these domains. Now, in the flow or stream, so just like a river flows, the thoughts are flowing. So again, there can be 2 types of abnormalities. One is when there is problem in the speed or tempo of the thought. So the speed with which the thoughts are flowing, that is abnormal. And second is when there is problems of continuity. So let us discuss the first, that is speed. Again, speed can be, there can be increased speed or there can be decreased speed. Now, in increased speed, the first a very important phenomena which we are going to discuss is flight of ideas. Very, very important. So as the name suggests, always try to, correlate things with the names. So as the name suggests, flight of ideas, as if the ideas are on a flight. That means the thoughts are moving very, very fast. So there is one thought, second, third, fourth, fifth. The thoughts are coming very, very fast. So the thoughts follow each other rapidly. Suppose you ask something, from the patient. So if you ask something from the patient, so I ask a patient some question. So patient may say so many things because the thoughts are coming very, very fast. But ultimately the person does not answer my question. So we say that the goal is not reached. Now, one thing is very interesting in flight of ideas, although the patient will be saying so many things because the thoughts are moving very fast, but these thoughts, although are illogical, they may be connected somehow. And this is very important to identify this phenomenon in the question. So these connections can be by chance. For example, the patient may say like this, my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So as you see, these thoughts, they are not making sense, but they're connected by chance. So one thought is connected by the previous thought. My name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So this is chance connection. And sometimes they may also be connected by what is known as clang association, by rhyming words. For example, patient may speak like this, Ram can sing, birds have wing, I am the king, the phone goes tring tring, the weather is spring, bring bring bring. So again, these are although illogically connected, but this connection is by rhyming. So this is known as clang association. So this is flight of ideas. And very important to remember, flight of ideas is seen in mania. It is seen in mania. Now, let's talk about when the speed is decreased. So, one important interesting phenomenon is circumstantiality. So, what is circumstantiality? Here, the thinking proceeds slowly, but person gives unnecessary or trivial details. So, patient may speak some unnecessary details which you have not asked for. But ultimately the patient answers your question. So the goal is reached. This is known as circumstantiality. For example, you ask the patient, who is your favorite actress? So person may say like this, I like the acting of Alia Bhatt. Even Katrina Kaif is very nice. I also like somehow Kareena Kapoor. But my favorite actress is Deepika Padukone. So patient is giving some unnecessary information and subsequently is answered the goal. So this is how the patient is reaching to the goal. So this is circumstantiality. Now, in the disorder of continuity of thought, now one very important phenomena which you should remember is perseveration. Now, what is the meaning of perseveration? Perseveration means to repeat. So perseveration, again you can remember it like this, 3 P's. P for perseveration, the thought persists. The thought persists beyond the point of relevance. So one thought is persisting. That means there is some problem in the continuity and the person is stuck at one thought. And that thought is persisting now beyond the point of relevance. So initially it was relevant, but now it is keep on repeating and it has lost the relevance. So this is perseveration. So for example, we ask the patient, what is your name? The patient says, my name is Mukesh. This is correct and relevant. Now when I ask the patient, what do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. So now this thought is now persistently getting repeated beyond the point of relevance. So this is perseveration. Now 2 important conditions in which you may find perseveration. First is organic mental disorders. So very important. First is in organic mental disorders. And in schizophrenia. So these are 2 important conditions, organic mental disorders and schizophrenia, where you may find perseveration. So the question may be, a patient is repeating same thing again and again, or the example which we just discussed, that can be a question, and you may be asked what is the phenomena and where it is seen. Now let's talk about the next abnormality of thought, that is the content. So first and very important condition under this is delusion. Delusion is a psychotic symptom which we'll discuss. Now, very important to understand what is a delusion. So, delusion is a false, fixed, unshakable idea or belief. So, it's a belief which the patient is holding, and it is a false belief. It is not correct, but it is fixed in the mind of the patient. And if you try to change, it is not changing. It is unshakable. And the person is holding it with extraordinary conviction. The person is totally convinced. Whatever reasons you tell him that why the thought which you're holding or what you're thinking is wrong, the person will not change. So he's holding it with extraordinary conviction. For example, a 20-year-old male is brought to us by the parents, and the person is convinced that my neighbors want to kill me. And he's been saying this thing for quite some time, and he's also behaving on those thoughts. He's acting on those thoughts. But family member says there is nothing like this. The neighbors are very good. In fact, we have tried to call them and we have tried to, tell him that, nothing like that sort they're thinking of. But the patient is convinced. And, so much so that the father says now, yesterday he is planning to buy a pistol. So that, if the neighbors come and harm him, he may shoot them first. But the neighbors are not doing any such of those things. So this is what this patient is convinced. It's a false belief, but he's totally convinced and he's not changing the belief despite being given contrary evidence. Also, such, these delusions, they're unexplained by the cultural, social or educational background of the person. So this thought is basically not shared by others, just by the patient. So it is not, explained by the cultural or social or educational factors or background of the patient. Now, this differentiated from certain things. For example, in many cultures, there is a belief that if a black cat crosses your way, something bad might happen. So what is this? Again, it's a false type of belief, but many people are in the society or in the culture are sharing it. So that is a superstition. So it differentiates the last point from such things like superstition. Now, there are various types of delusions. Let us discuss. The first is delusion of persecution. As the name suggests, persecution means to harm or to kill. It is the most common delusion out of all the delusion in psychiatric disorders. So patient believes that someone wants to harm him or kill him. The example which we just discussed is an example of delusion of persecution. The patient may come and say, to the doctor, sir, I know even you are involved. Even you are planning to harm. So it can involve any person. This is delusion of persecution. Next is delusion of reference. Now, as the name suggests, reference means the patient believes that everything which is occurring around is in reference to him. So, patient may believe that someone is talking about him or someone is spying him or spying on him. So, patient may be walking on the street. There is, two strangers standing very far from him. But the patient is convinced that those two people are talking about him. You ask him, how do you know? You cannot hear what they're saying, but the patient is convinced. Or the patient may say that, someone is spying on me. So this is delusion of reference. Now next is delusion of grandiosity. So grandiosity means big. So here patient makes false big claims. So patient believes that he has some supernatural powers, he can do anything just by a snap of his finger. Or he may claim that he knows famous people. He may say that, Prime Minister calls me every day and asks me what should I do. President of United States called me and asked me, what should I do? How should I go ahead with these things? So patient makes such big claims, or patient may claim that, he has vast knowledge. He has read all the books in the universe, or he has vast, amount of money. Although there may be 0 rupees in his bank balance, but he may claim such big things. He may say, I am God. So this is delusion of grandiosity. Again, it's a psychotic symptom. It can be seen in psychotic disorders like schizophrenia, and also it can be seen in disorders like mania. So this is delusion of grandiosity. Then next is delusion of nihilism, or also known as delusion of negation. Now it is just the opposite. Now the patient has become extremely negative. Patient denies the existence of his body. Patient may say that, this body of mine is a dead body. It's dead from inside. Or he may claim that, the family members, his loved ones are all dead. They're just plank of card moving. Or the person may claim that, again, this world is all a dead world. Everyone around or everything around is all dead. So this is delusion of nihilism or delusion of negation. Again, it's a psychotic symptom. It can be seen in various psychotic disorders like schizophrenia, and also it can be seen even in depression. It can even be seen in depression. Okay. Now, there is another interesting phenomenon associated with this is Cotard syndrome. So Cotard syndrome is basically a term which is given when delusion of nihilism is present in a patient with depression. So that is termed as Cotard syndrome. Now, next, again interesting delusion is de Clermont syndrome, also known as erotomania or also known as delusion of love. Please understand, love is, when you say that, I am in love with someone, but this is delusion of love. So what is this? So patient believes that someone else is in love with the patient. So patient says that that other person loves me. So a 20-year-old female may claim, film star or superstar is in love with me. She may claim, that, the next movie which is coming of that actor, is to tell me that he loves me. Although the poor actor might have never seen that girl. So this is de Clermont syndrome, delusion of love or erotomania. Now, another interesting delusion is Othello syndrome, also known as delusion of infidelity. So what is infidelity? Infidelity means when the partner or spouse is cheating, or it is also known as morbid jealousy. So what is this? Here the patient believes that the partner or my spouse is cheating or is having an affair. So again, the patient, although it is not true, but the patient is, again giving illogical explanation and saying that my partner or my spouse is having an affair. Again, it can be seen in certain psychotic disorders, but there is one important substance also. Person who consumes this substance for a long time may also develop this delusion of infidelity, and that substance is alcohol. So in alcohol also, many times we may encounter delusion of infidelity. Now let's talk about another interesting delusional phenomena, that is delusional misidentification syndrome. As the name suggests, here the patient claims the identity of someone, of a person, as something else. So there is misidentification of the identity. Now two important syndromes under this we are going to discuss. One is Capgras syndrome. So what is Capgras syndrome? Here the patient believes that someone, usually a closely related person, has been replaced by an exact double. So let us take an example. So patient is admitted and the wife comes and meet him, and the patient says that I know you look like my wife, but you're not my wife. So patient says in fact that you are a hospital nurse. You're not my wife, but a hospital nurse who has come in disguise of my wife. So here the patient is believing that a close person, like in this case the wife, has been replaced by someone else. So this is Capgras syndrome. So you can remember, again a trick to remember, just see the name and you'll remember. So Capgras syndrome, the name is telling you close person replaced by a stranger. This is the patient's belief. Now physical appearance, as in this case we know it is the same. The patient acknowledges that you look like my wife, but you're not my wife. So again, another trick to remember is, always see, with whom the patient is arguing or fighting. Like in this case, he is arguing with the close person. So in Capgras syndrome, the person argues with the close person. Another important phenomena under this is Fregoli syndrome. Now it's the opposite. Here the patient believes that a familiar person is imposing as a stranger. So patient believes that a familiar or a close person is now coming in front of the patient as a stranger and can take multiple appearances. So let us take another example. So patient Mr. F or patient Mr. Freg, he was walking and he see a stranger. So let us call him S1. So he sees a stranger whom he have never met, and he says, or he believes, and he says to this stranger that, I know you look like a stranger, but you're not a stranger. You're my wife. Why are you coming in front of me as a stranger? So here he believes that the wife is imposing as a stranger. Now let us say he walks forward and again he meets another stranger. Let's call him S2. And again to this stranger he says, again that, I know you look like a stranger, but you're my wife. What are you doing here? Let's go home. So this is Fregoli syndrome. So now again in Fregoli syndrome, the physical appearance is different. Patient is acknowledging that I know you look like a stranger, but then he believes that that stranger is not a stranger but a familiar person. So again, another trick is, whenever in this question you can see the patient is arguing or fighting with whom? Is fighting with the stranger. So another trick so that you can remember Fregoli syndrome. So these are some of the important delusions. Now let's talk about the third important domain of thought, which is form. Now form basically means structure or organization. Just like things around like this pen or anything around you, everything has a structure. Similarly, our thoughts also have a structure. So they have a start, they have a middle part, and they have a end. Now, when there is abnormality of the form, we say it to be formal thought disorder. So formal, so again it is derived from form. So there is abnormality of form. That means there is disorganization. And many of these formal thought disorders may be seen in schizophrenia. So we'll discuss some of the important phenomena under this. Now, let us take a normal thought and then we'll compare it with the abnormalities. So let us say a normal thought is A followed by B, C, D, E. So that means everything is logically connected. And let us say another thought. Suppose you want to have coffee outside. So what will be the thought? The thought might be that I'll book a cab, I'll reach the cafe, I'll order coffee, I'll drink, I'll pay and come back. So if you can see, this thought has a beginning, it has a middle part and it has an end. So we'll compare this when we'll talk about the abnormalities. First is loosening of association. So again, just see the name. The association between the thoughts have loosened. So there is problem in the organization. So there is a break in the logical connection between the thoughts. That means the sentences, will not make any sense. Word you will understand, but sentences will not make any sense. So let us compare it with the normal thought we had just, discussed. So here the thoughts may be like this: C followed by A, then E, B, D. So everything is again illogically connected. Or suppose if you ask this person, who's having loosening of association, what will you do if you want to have coffee outside? The patient may say, I will order, I will come back, I will reach cafe, I will, black shirt, drink, I will book a cab. So again, if you see, everything is illogically connected. You're able to understand the words, but you're not able to understand the meaning of the sentence. So this is loosening of association. Again, it can be seen in disorders like schizophrenia. Now next is derailment, also known as night's move thinking. So again, what is derailment? The meaning of derailment is, the rail was moving and suddenly it got derailed. Or, how does a knight moves in chess? It goes straight and suddenly takes a turn. So this is what is happening in the thought. The person jumps off the thought or jump off the track to move to a different topic. So person is speaking on the same topic, on a normal topic, and suddenly without any reason you will say that the person is shifted, has jumped off the track to a new topic. There is no logical association between this jumping off. This is derailment or night's move thinking. So for example, in this case again, the patient, was saying A, B, and rather than going to C on the track, suddenly got derailed and started a new topic, L, M, N. So like this, again, let us say if we ask him, what will you do if you want to have coffee outside? The person may start like this: I'll book a cab, I'll reach cafe. And suddenly the person may start, talking about something new. So the person may start a new topic. The weather is very cold, I bought a new muffler, I'm also planning to buy a sweater, black in color. So person is shifted or jumped off to a new topic. This is derailment. Next is tangentiality. So again, just see what is a tangent to a circle. So a tangent to a circle is a line which touches a circle at one point and it goes away. Does a tangent ever return to the circle? No, a tangent never returns to the circle. This is what is happening in the thought. The reply of the person is oblique or tangential. So person touches the topic and moves away, and the goal is not reached. Now, if we compare it with circumstantiality, wherein we had discussed the person would give unnecessary trivial information. Now let us take the same example. Let us ask the person, who is your favorite actress? So person may say, I like the movies and especially the dance numbers, and my favorite actor is Shahid Kapoor, and I was watching his last movie and it was very good. it was Kabir Singh I was watching, and I like him being portrayed as an orthopedic surgeon. In fact, my dream also is to become an orthopedic surgeon. So if you see, the person has touched the topic and he has went away, but he has never answered the question back. This is tangentiality. So here the goal is not reached. Next is neologism. So again, from the word itself, what is neo? Neo means new. Logos means word, new word. So there is a completely new word or phrase the person has derived, whose derivation you cannot understand. So this word, suddenly out of nowhere, the person is derived a new word which does not mean anything in the language known to the person. So for example, the person is an English speaking person, you're talking to the patient and you're talking about certain things, and suddenly out of nowhere the person starts saying that I bought a new tack lit pit mat. And you are confused, what are you saying? What does this mean? I don't know. The person only knows English and there is no such word in English. And subsequently he points out to his watch and says, I bought a new, this new tack lit pit mat. So he's just, derived a new, word out of nowhere. So this is neologism. Again, it can be seen in disorders like schizophrenia. Next is incoherence or word salad. Again, the thought is incomprehensible, means you cannot understand. It is not making any sense. So patient may speak like this, I will go umbrella, black fly, water. Again, this, is not making any sense. This is incoherence or word salad. Next is talking past the point, also known as verbatim. So again, person is talking around the point. Now the reply shows that he understood the question. So you ask a question to the patient and he replies back. And his reply is telling you that maybe he's understood the question, but he's deliberately talking about an associated topic. For example, you ask the patient, what is the color of grass? And the person replies, red. So this red is telling me that he understood I'm asking about a color. And it's not that, in his area, the color of the grass is red. So this is talking past the point. Now, one important point about this is Ganser syndrome. So when initially it was identified, talking past the point, it was identified in a lot of prisoners. So talking past the point, in prisoners, this was termed as Ganser syndrome. So you can remember it like this: Ganser syndrome seen in gangsters. But now we know that it can be seen even in other populations. So these are the disorders of form. Let's talk about the last domain under thought, which is possession. Now normally, we know that we possess our thought. So when there is abnormality of possession, either there is a loss of control over the thoughts, or there is loss of sense of possession of thinking, that these thoughts are not mine, or they're influenced by someone else. Two important entities under this is, first is obsession. So you can remember it like this: obsession, it is a disorder of possession. Now what is obsession? These are repetitive thoughts, images or impulses which come in the mind of the patient, and the person in obsession acknowledges that these are my own thoughts, but the person is not able to control them and it appears senseless. So this is obsession. We'll talk about in detail again about obsession when we'll talk about obsessive compulsive disorder, that is OCD. Next is thought alienation or passivity phenomena. Again, as the name suggests, alien. So as if the thoughts are alien. They're not under my, they're not mine, or someone else is influencing them. So again, under this, there are three important phenomena. First is thought insertion. So person is experiencing that his thoughts are getting influenced by outside. In insertion, patient, experience that someone is inserting thoughts in his mind. So person may say, sir, I've got this thought in my mind that I should go and buy a chocolate for myself. But sir, this thought is not my thought. Someone else has inserted this thought in my mind. This is thought insertion. Next is thought withdrawal. As the name suggests, here the person experiences that the thoughts are taken away. So person may say that, there was a thought in my mind a few minutes back, but I don't know where it has gone. Someone has taken away my thought. This is thought withdrawal. And lastly, thought broadcast. Patient experiences that my thoughts are getting broadcasted outside, and people around me are able to know my thoughts. So person may say that, I walk in a room full of people and everybody is able to know my thoughts. My thoughts are getting broadcasted. My thoughts may be getting broadcasted through television, radio, newspaper. So my thoughts are getting broadcasted. So this is thought insertion, withdrawal and broadcast. So again, these can be seen in schizophrenia. Now let's talk about the next aspect of the MSc, which is perception. So what is perception? So, what we perceive from our sensory organs is perception. So, we hear things, we see things, we smell things, we taste, and we experience things by touch. So when there is abnormality under these domains, then we say it is a disorder of perception. So person may, report of seeing something or hearing something, which may not be, evident to anybody else. This is abnormality of perception. Now first under this is illusion. Illusion is a false perception. It's abnormality of perception of a real object. So for example, let us say a person is, sleeping in the middle of the night. He wakes up and he says that he can see. So the person claims that he can see a snake under the bed. So he's able to see it. It's a abnormal. So it's a perception. So he, suddenly screams, family members rush in, they switch on the light, and the person then sees, oh, actually it was a rope. So this snake is a false perception. So this snake is a false perception of a real object. What was the real object? The real object was rope. So, all of us might have experienced this. Another example, you're sleeping, you wake up in the middle of the night and you say that I can see someone standing behind the windows. You switch on the light. Oh, it was actually the curtains which were moving. So this is illusion. Next is hallucination. Now, what is hallucination? Again, it's a false perception. It's a perceptual abnormality without any real object. So this is important. Without any real object, person is experiencing some perception. Again, just like delusion, hallucination is also a psychotic symptom. Now, please understand, just like any real object, let us say this pen, it's a real object. So what are the characteristics of this pen? It is very clear. I can see it very clearly. You can see it very clearly. Now, where is this pen located? Is it located in my mind or is it located in the external space? This pen, of course, it's a real object. It is located in the external outer objective space. Now, can I just wish and make this pen disappear? No, I cannot do that. I may throw this pen, but the pen will still remain. So the existence of this pen is not under my control. So these are the characteristics of any real object. Now let us understand the characteristics of hallucination. Now hallucination to the patient is very clear, as vivid as real. So person is experiencing as if it is a real object. And again, to the person, it is occurring in the outer objective space. So person is experiencing in the external world, and person may expect that even you would be able to experience it because it is occurring externally. And the person says that it is independent of the will of the person. So it is occurring on its own. He cannot control it. So if you see, a hallucination has all the characteristics of a real perception, but the only thing is that it is false. It is not true. Okay. So the person would, to him, it is appearing that it is actually there, but we know that it is not there. Now, for example, in this movie, a very famous movie, in this, the actor, is able to see and hear Mahatma Gandhi. We know Mahatma Gandhi is no more with us, but he's able to see him clearly and able to hear him clearly. Even he is conversing with him. Okay. And again, it is occurring in the external space, and, it comes and goes on its own. So it is not under his control. So classical example of hallucination. Now, there is another interesting abnormality, which is pseudo hallucination. Now, pseudo hallucination, as the name suggests, again, it is similar to hallucination, like it is very clear. It is independent of the will of the person, but the difference is where it is occurring. Now, a hallucination would occur in the outer space. For example, the person may say that he is able to see, a pen. So there is no pen in my hand, but the person says that there is a pen. So that is a hallucination. Now, if he is able to see this pen in his mind, okay, again, but it has all the characteristics that it is clear, it is independent of the will, then we say it is pseudo hallucination. So any example of hallucination can be a example of pseudo hallucination. The difference is where it is located. So if it is located in the inner space, inner subjective space of the mind, then it is pseudo hallucination. Now let's talk about types of hallucination. So first is auditory hallucination. So as the name suggests, auditory means the person is able to hear something. Patient is able to hear things. So it may be simple clap or a bell or a dog barking or even voice of a human. So it could be anything which the person is able to hear and it is not heard by anyone else. Okay, so it's a false perception without any object. Next is visual hallucination. Visual hallucination. Now, also in auditory hallucination, please remember it is the most common hallucination. So out of all the psychiatric disorders, auditory hallucination is the most common. Next is visual hallucination. Again, as the name suggests, person is able to see things. Again, it can be any object, any animal, or even a human. The person is able to see. Others cannot see. This is visual hallucination. Now, again, hallucination, it's a psychotic symptom. It can be seen in disorders like schizophrenia. But when it comes to visual hallucination, of course, it can be seen in schizophrenia. But one very important disorder which you should remember for visual hallucination is organic mental disorder. So whenever there is a visual hallucination, in the question or clinically, if you see, try to see whether there any organic disorder associated, because again, in organic mental disorders, visual hallucinations are the most common. Next is olfactory hallucination. As the name suggests, it is smell. So person is able to smell something which is not, others cannot smell. So person walks in a room full of people and say that there is a foul smell coming. Nobody in the room is able to, smell anything like this, but the person is able to. This is olfactory hallucination. Then gustatory hallucination, as the name suggests, gustatory is taste. So there is nothing kept on the tongue of the patient, but person is able to experience some taste. This is gustatory. Again, olfactory, gustatory hallucinations, these can be seen in disorders like schizophrenia. But again, olfactory and gustatory hallucination may also be seen in disorders like temporal lobe disorders, such as temporal lobe epilepsy. So other hallucinations may also be seen, but again, these are very, hallucinations which may be seen in temporal lobe disorders like epilepsy. Lastly, it is tactile hallucination. So tactile hallucination, as the name suggests, there is an sense of touch. So person is experiencing some sensations in his body, under his body. Also known as formication, where the person may experience that there are small insects crawling over or under his skin. So person, may claim that although he may not be able to see these insects, but he claims that yes, he can experience those insects crawling under his skin. He may just say, please make an incision, doctor, cut them out, make them out of his body. There is no such insect, but he's experiencing it. So this is formication, sometimes also known as cocaine bugs or magnum bugs. So again, as the name suggests, cocaine bugs, because it again can be seen in people who consume or use cocaine. So many times in the patients who abuse cocaine, you may see there may be scratch marks, which may be result of these cocaine bugs. So person, because feel that there are insect crawling, they may start scratching. So scratch marks may be seen. So these are 5 important types of hallucination. Now there are some, special hallucinations. One important hallucination is reflex hallucination, which is also known as morbid synesthesia. So reflex hallucination now. So it is special because some difference from the normal definition of hallucination. So normally we say that hallucinations, they do not require any real object, but here what is happening is a real stimulus in one sensory modality like hearing, visual or olfaction. So there is a stimulus in one sensory modality, which is a real stimulus, a real object. It is producing, so this is producing hallucination in a different modality, in another modality, not the same modality. So it's like a reflex. So person experiences a real stimulus in some modality, and in reflexly there is a production of a hallucination in some other modality. This is what is known as reflex hallucination, also known as morbid synesthesia. For example, a person says that whenever I hear the ringtone of my phone, this phone ringing is a real stimulus. So anybody can hear the phone ringing. It is actually occurring. So it's a real stimulus. In which modality? Person is able to hear. It's an auditory modality. The person says, whenever my phone rings, I hear the ringtone. I see a man walking around. Now this man, which the person says nobody else can see. So it is a hallucination. And what type of hallucination? It's a visual hallucination. So an auditory real stimulus is producing hallucination in a different modality, here in this case visual. So this is reflex hallucination. So again, reflex hallucination can be seen with the use of hallucinogens such as LSD, lysergic acid diethylamide, and even other substances. Now, so let's try to understand. We have discussed delusion, we have discussed hallucination. So delusion is, both are psychotic symptoms. Delusion is a false belief. It is something which the person is believing, while hallucination is a false perception. It is something which the person is experiencing through the sense, through the perception, through the sensory organs. So delusion, the person may say that I know that this is happening, while in hallucination the person may say I see or I hear or I smell. So this is the difference between delusion and hallucination. Now let's talk about higher mental functions in the MSc. So higher mental functions are basically cognitive functions we assess in the MSc. First is orientation. Orientation basically is awareness of the self and surroundings with respect to time, the place or person. So suppose a person says, although let us say it is morning, but the person may claim it is night time, or the person may claim it is 10th of October 1990. So person is not oriented to time. Or let us say the person is at his home but is claiming that he is at his office. Or person, he is not identifying the family members around. So this is disorientation, when the person is not oriented to time, place or person. And disorientation may be seen in disorders like delirium. So D for disorientation, it may be seen in delirium. Next is attention. So again, what is attention? Attention is basically ability to attend to a specific stimulus. So without getting distracted. So a teacher in the class may say, pay attention. So pay attention to what I am speaking. Don't get distracted by voices around. So this is attention. Now, how do we check attention or how do we test attention in a patient? So it is tested by a test known as digit repetition or digit span test. So here we give some digits to the number and ask him to repeat those digits after us. So again, it has two types. So one is digit forward test. As the name suggests, we ask the person to repeat the digits in the forward direction. For example, I give this digit 2, 7 and the person also has to repeat 2, 7. If he is able to do this, I increase the number of digits. So now I say 4, 1, 9. The patient also says 4, 1, 9. So we say if the person is able to repeat up till 5 to 7 digit numbers, his attention is intact. So digit backward test is what it is when the person has to repeat the digits in the backward direction. So I give the number 1, 6, person will say 6, 1. So then I say 2, 3, 8, 1, the person will say 1, 8, 3. So if the person is able to repeat 3 digit number to 5 digit number, we say his digit backward test is intact. So these tests are used to check the attention. So out of the two, if you're asked, better answer will be, if you have to choose one, digit forward test will be a better answer. As in digit backward test, other mental processes are also involved. So one, if you have to choose, it is digit forward test, otherwise digit repetition test or digit span test. Now second is concentration. So attention was for short duration. So what is concentration? Concentration means sustained attention. So many times, students say, sir, after reading for half an hour, I lose concentration. I'm not able to concentrate. So concentration is sustained attention. Again, how do we check concentration? It is checked by a test known as serial 7 subtraction test. That is 100 minus 7 test. So what we do in this test, basically we tell the person to subtract 7 out of 100. And whatever the answer is, keep on subtracting. Okay. So let us say the person says 100 minus 7, 93, then 86, then 79, 72, then 65. So if the person is able to do at least, correctly 5 times, we say that the concentration of the person is intact. Then we assess the memory. Now in memory, first is the immediate or the short term or working memory. So this is basically based on the duration. So it is basically memory of the past few seconds. So if you are able to remember, what is the last topic we just discussed? We discussed concentration. That means your immediate or the working memory is intact. So again, we don't have to take any other test for this. So all the tests of attention or concentration are also checking your immediate memory. And if you choose one particular test, again, digit forward test may be the best answer. Next is recent memory. So again, recent memory, as the name suggests, memory of the past few minutes or hours or past few days. If you're able to remember things which happened during this time, that means your recent memory is intact. So what is the test which we do to check it? We use a test known as 24-hour recall method. We ask certain events which occurred in the past 24 hours and we try to cross-check whether the person is saying it correctly. Very simple and common question which we ask the patient is, what did you had in your last meal? So we are asking something which happened maybe few hours back. So what are we checking? We are checking recent memory. And last is remote memory. So remote means far, distant. So it is memory of the past few months or maybe years. So how do we check it? We can check it by asking certain personal information. So suppose a 30-year-old male comes and we are checking his remote memory. We may ask the name of his school, or the name of his wife, the name of his children. Okay, such questions, personal questions which have occurred in the past. Or we may ask certain historical events which have occurred in the past. Let us say, name two prime ministers in the last two prime ministers of the country. Okay, so historical events which have occurred during the lifetime of the patient. So through that we check the remote memory. Abstract thinking, then we check abstract thinking. What is abstract thinking? It is the ability to understand hidden meanings or to form concepts. So we try, so normally all of us have abstract thinking. So we check abstract thinking by a simple test known as proverb testing. Okay, so we give a proverb to the person and we ask the meaning. So generally proverbs carry a hidden meaning. For example, we can ask this proverb, journey of 1,000 miles begin with a single step. So we ask the person to explain it. So it means that if you have to cross the 1,000 miles, you have to take one step at a time. Okay, so if you have to achieve your goal, you have to make it short and step by step you have to achieve. But the person says, so this means that if I've taken one step, that means I've covered 1,000 steps. No, that does not mean this. That means the person is not able to understand the deeper meaning. Is only able to understand the superficial or the concrete meaning. So we say loss of abstract thinking is known as concrete thinking, and it may be seen in disorders like schizophrenia. Now another test which can be used to check the abstract thinking is similarity testing. So we ask similarity, such as we ask similarity between a car and an airplane. So if the person is able to tell the functional similarity, for example, the person says that both of them are means of transportation, that means the abstract thinking is intact. But let us say the person says that both have tires, both are made up of metal. So person is not able to tell the functional, but only the anatomical similarities. That means it is concrete thinking. So this is another test which is used to check abstract thinking. Now next is, which we check in the MSc, is the judgment. So what is judgment? So just like in the courtroom, the judge hear all the evidences and then make a judgment. So judgment is making a right decision after analyzing the choices. So again we try to check the judgment, and one interesting specific judgment which we check is one is known as test judgment. So in test judgment we give a hypothetical situation to the patient and we ask the patient what he will do. So very commonly we ask this question, suppose the neighbor's house catches fire, what will you do? So if I ask you, you may say, sir, we'll call the fire brigade, we'll try to extinguish the fire, we'll try to help the neighbors. So all these answers will be correct. One of the patients said, sir, what I'll do? I'll pour kerosene. So this seems to be impaired judgment. Okay. So impaired judgment may be seen in psychotic disorders like schizophrenia. We'll talk about neurosis and psychosis in just a while. And lastly, what we check in the MSc is the insight. Now, in medicine or surgery, you may not check insight, but in psychiatry, we check the insight of the patient. What is insight? Awareness of the illness. Is the person aware that he is ill? Because many times, patient may say, sir, I am fine. I think my family members have gone crazy. You please, treat them. But it is actually the patient who is suffering from some illness. So person may not have that insight. So we check the insight of the person. So now there are certain grades, 5 important grades of insight. Grade 1 is when there is a complete denial of the illness. So we have a 30-year-old male patient who says, no sir, I am not having any illness. I don't think I am having it, but the family members and by that when you're talking to the patient, you are able to understand that the person is having some psychiatric problem. Grade 2 is when there is slight awareness of being in, but again patient may say, yes sir, I think some issues are there, but again during the same interview only the patient may just say, deny it, no, I think I'm fine. This is grade 2. Then grade 3 is the person says, yes, I am having illness, but he attributes it to some external or physical or medical or some unknown factors. For example, the person may say, because I am having a lot of work burden in my office, people are not good, so that is why I am having some trouble. So he's attributing it to some external factors, okay, or he may attribute it to some physical factors, or because of the temperature, or attribute to some medical illness he may be suffering from, let us say diabetes, or some unknown factors. This is grade 3. So you see the insight is increasing. The next is grade 4, also known as intellectual insight. So by intellect, he is aware. So person is aware that he is ill because of his own irrational feelings or emotions, but he is not applying the knowledge to change his behavior. So in this case, the patient is agreeing, yes, there is some problem because of my thoughts, my feelings, but you advise him to take medicines, you advise him to come for regular session, but the person is not doing that. So he's intellectually, he's aware, but he's not applying it to change his behavior. This is grade 4. And the highest level of insight is grade 5. That is known as true emotional insight. Here the person is aware of the illness and also starts applying the knowledge to change his behavior. So now the person starts taking medicines regularly, starts coming to the therapy sessions, starts changing his lifestyle routines. So this is grade 5. So these are the grades of insight. Now, when we divide the psychiatric illness into two, neurosis and psychosis, so we say in neurosis the insight is present, while in psychosis the insight is absent. Now, in the classification of disorders in psychiatry, so currently we have two classificatory systems. Both of them are basically based on the symptoms. So one is ICD-11, so it is the latest version, so International Statistical Classification of Disease, 11th revision. It is given by World Health Organization, the WHO, and the other is DSM-5. Again, it is Diagnostic and Statistical Manual of Mental Disorders. It is the 5th edition. So ICD not just describes psychiatric illness, but it describes all the other conditions like medicinal, surgical, dermatological, while DSM only describes the psychiatric illness or the mental disorders. And it is given by APA, that is the American Psychiatric Association. So, but we can follow either of these two. So ICD-11 has recently been, has replaced ICD-10. A lot of changes which were made by DSM-5 have also been made by ICD-11. So we'll discuss some of the important changes of both when we talk about relevant disorders. Now, historically, the psychiatric disorders were classified into two. Again, this is an older classification, older way of classifying. We have better ways, but still you should know. Okay, so organic disorders and functional disorders. So organic disorders were generally when there was a visible or a demonstrable cause. So let us say somebody had a head injury after which he developed some psychiatric symptoms. So if you see, you will see the injury, you do a brain scan, you will see the injury and you can see that. So suppose another example, someone developed some infection, encephalitis, after that developed psychiatric symptoms. If you do a blood count, CSF count, you will be able to see the infection. There is low sodium in the body and the person is developing some psychiatric symptoms. You check the sodium level, you will be able to see. So those were termed as organic disorders. And functional, on the other hand, were when there was no visible or apparent cause. For example, let us say if someone is having depression, you do a brain scan, you may not find any finding, or you do a TLC count, blood count, you may not find anything visible. So those were termed as functional. But now we know even depression, schizophrenia, all those have some or the other etiologies, maybe at a very, very smaller, minute level, like neurotransmitter level. So nowadays nothing is functional, but this is an older way of classifying. So we already discussed, in organic disorders, which hallucination will be more common. Visual hallucinations may be more common, while in functional, auditory hallucination may be the more common. Now, functional disorders are further divided into neurosis and psychosis. Again, it's an older classification, but let us try to understand some of the important differences. In neurosis, we have discussed the insight is present, while in psychosis, it is absent. Reality testing, touch with reality. So whether the person is able to differentiate what is real and unreal, it is intact in neurosis while it is impaired in psychosis. Person is not able to sometimes differentiate what is real and what is unreal around. Judgment, again, as we have discussed, neurosis it is intact while in psychosis it is impaired. And again, very important, delusions and hallucinations are absent in neurosis, and we have discussed these are psychotic symptoms, they are present in psychosis. Some of the examples of neurotic illnesses like anxiety disorders, obsessive compulsive disorders, even depression, let us say. While in psychosis, there are examples like schizophrenia or delusional disorders or mania. But again, we have discussed even in depression, person may develop some psychotic symptoms. So it is psychotic depression. So again, person can move from one side of the table to the other. So it's not a very crystal clear classification anymore, but still you should know the difference between neurosis and psychosis. Now, lastly, whenever we talk about any disorder, so suppose we'll talk about depressive disorders or schizophrenia. So whenever we use this term, disorder to any condition, that means it is it is fulfilling the symptom criteria. all the criteria which are there, it is fulfilling it. It is fulfilling the duration criteria. Let us say for depression, it is 2 weeks, so it is fulfilling. And very important is, in a disorder, there is some level of impairment of functioning, or the symptoms are causing clinical distress to the patient. So it may be, it may be less impairment, it may be severe impairment depending on the severity of the condition. So impairment in terms of work or social activities or personal activities. So there is some form of impairment in the person. So this we call as disorder. So now let us discuss about schizophrenia and other psychotic disorders. So now we are going to talk about important psychotic disorders. So schizophrenia is a prototypical psychotic disorder. So when we talk about the history, so Emil Kraepelin was the person who identified, certain patients, which now when we read those descriptions, it looks similar to schizophrenia, and he termed those patients as dementia precox. Then Eugene Bleuler was the person who coined the term schizophrenia. So schizo means split, phrenia means mind. So he coined this term. So now which is the term which we use. So he also gave, 4 important symptoms. Now when he coined the term schizophrenia, he tried to describe it and gave 4 symptoms which are known as Bleuler's 4 A's. So what are these 4 A symptoms? So first is loosening of association, affective flattening. So we already know what is loosening of association. It's an abnormality of the form. Affect flattening, again flat affect, again we have discussed, it is seen in schizophrenia. Then autism and ambivalence. So these are the 4 A's. So what is autism? Here according to him, that the person having schizophrenia would live in his own world, would have some fantasy thinking. So he described it as autism. And last is ambivalence. What is ambivalence? So meaning of ambivalence is when you are not able to decide, inability to make a decision. So a person with schizophrenia, may be staring at a pen which is kept on the table, and he's staring for maybe hours, and in his mind he is thinking whether he should pick this pen or not pick this pen. So this is ambivalence. These are Bleuler's 4 A's. Then came another gentleman, Kurt Schneider, who also tried to describe the symptoms, and he gave certain symptoms which are known as Schneider's first rank symptoms, or SFRS. So let us understand what are these SFRS. So the first 3 symptoms, one is audible thoughts or thought echo. That means person is able to hear his own thoughts. So person says, sir, there is a thought which comes in my mind, and subsequently I hear a voice which is repeating the same thought. Then next is voices discussing about the patient. It's a type of third person auditory hallucination. So person says that there are 2 or more voices which are talking to each other and which are discussing about the patient. So here the person is third person in their conversation. So that is why these are third person auditory hallucination. And another auditory hallucination which is under the SFRS is that the voices are commenting on one's action. So patient says that whatever I am doing, the voices are commenting, or they are giving a running commentary of whatever I am doing. So for example, person says, I wake up in the morning and there is a voice which says, now he's woke up from bed, now he's going to the washroom, now he's come back, now he's going to the kitchen. So there is a running commentary of whatever the person is doing. So these are the 3 auditory hallucinations which are part of SFRS. Now next 3 we have already discussed in the basic: thought insertion, withdrawal and broadcast. So the thoughts, the person are not under the possession of the person. Patient experiences this. So these are thought alienation phenomena again which are under SFRS. Now next 3 are the made phenomena. So you can remember it with the mnemonic IFA. So there are IFA awards, so you can remember it with IFA. So patient experiences his impulses are urges, or his feelings or his actions are influenced by others. So for example, person says there is a urge to stand up and go out. I am getting this urge, but person says, oh, this is not my urge. Someone is making me experience it. So this is made phenomena. Another example, person is crying and you ask, what happened? The person may say, this feeling of crying is not mine. Someone is making me cry. Or, made act. So person, let us say one patient has slapped another patient and you go and ask, why did you do that? So person said, sir, this act of slapping was not done by me. Someone made me do that. So this is made act. So these are made phenomena under SFRS. Now next is somatic passivity. So 11th symptom is somatic passivity. What is it? So patient is a passive recipient of a bodily sensation. So patient is experiencing some bodily sensations, and which he says are imposed by some external agency. So from the name you can remember, patient is a passive recipient of somatic or bodily sensations imposed by some external agency. For example, so there is a person, Mr. Bholu, who is having pain in the abdomen. So Mr. Bholu is having pain in his abdomen. So pain is a somatic sensation, and he says it is produced by some radio waves by the aliens. So this is what is known as somatic passivity, bodily sensation imposed by some external agency. Now 11th or the last symptom of SFRS is delusional perception. So what is delusional perception? Again, here the person experiences a normal perception, which is something anybody else can experience it, and person gives a delusional meaning to this normal perception, and both these phenomena are occurring together at the same time. So again, try to remember it from the name. Person experiences a normal perception and gives a delusional meaning to it. So this is known as delusional perception, and both these things occurring together at the same time. So for example, there is a person, Mr. Golu, who sees his wife wearing a red sari in red clothes. So anybody can see the wife wearing a red sari. So it's a normal perception, and immediately he starts believing that my wife wants to kill me. So he's totally convinced that the wife wants to kill him. So a normal perception has been given a delusional meaning. Here in this case, it is delusion of persecution. So this is delusional perception. So these are the 11 SFRS. Now let's talk about epidemiology. When we talk about the gender, it is seen that the prevalence is nearly the same, slightly maybe more in males than females if you choose one, otherwise we say it is nearly the same, maybe 1.1:1 ratio. But if this is given, you can mention it is similar. Now, peak age of onset in males and females is different. So in males, the peak age of onset is around 10 to 25 years. So most of the males would develop schizophrenia during this age, while in females it is slightly late. So the peak age is 25 to 35, and also it has another peak may occur at a later age. So it is bimodal. So but it is occurring at a later age. So now when we talk about the prognosis, we say that schizophrenia is a very severe mental illness. So males having it at quite a young age, again it is a poor prognosis. The outcome, if you compare it in males and females, we say males have a poor or a bad prognosis, while females have a good prognosis. As we have discussed, generally schizophrenia occurs at an early age, like we've discussed in males and females. So sometimes it occurs at a later age. So for the first time, the person may have schizophrenia at a later age. That is known as late onset schizophrenia. So person having schizophrenia for the first time after 45 years, after the age of 45 years, that is known as late onset schizophrenia. And again, what will be the prognosis? It will be a good prognosis in case of late onset schizophrenia. Now, coming to the etiology, again in psychiatric disorders, multiple factors play a role. So there is no one single factor which may be the cause of the illness. So multiple factors play a role. So let us discuss some of the factors. One is genetic factors. So again, genetic factors play an important role. Many times family history may be positive. Okay. So, again, the monozygotic concordance rate is higher than the dizygotic concordance rate. So schizophrenia is seen more if studies have been done on monozygotic twins and dizygotic twins. It is seen the other twin has higher chances in monozygotic pairs than dizygotic. So again, genetic factors do play a role, and higher risk of schizophrenia in family members of patient with schizophrenia and even bipolar disorder. So again, genetics do play a role, especially one of the factors you can remember, chromosome 22q11.2 deletion syndrome, also known as George or Velo cardiofacial syndrome. Nearly 30% of the cases may develop schizophrenia. Now, coming to the neurotransmitters, again, very, very important. Dopamine, there is a dopamine hypothesis which states that there is an increase in dopamine seen in patients with schizophrenia. So, dopamine is a very important neurotransmitter implicated in development of schizophrenia. Now, there are also other neurotransmitters. Even serotonin has been proposed to be increased in patients with schizophrenia. Again, we'll try to correlate, always try to correlate the etiology with the mechanism of action of drugs. So we'll talk about the drugs. So we'll try to correlate with the etiology. Also, even other neurotransmitters like GABA, glutamate, norepinephrine, acetylcholine. So all these and even more of these neurotransmitters may also be implicated in the development of schizophrenia. Now, another, in the etiology, one of the important risk factors of substance is cannabis use. So again, it has been seen many people who consume cannabis, again, they also may be vulnerable to development of schizophrenia. Coming to the symptoms of schizophrenia, let us discuss those symptoms and then we'll come to the criteria. So the first are the positive symptoms. These positive symptoms also known as psychotic symptoms. So two important positive symptoms. One is delusions. We have already discussed what are delusions. Most common delusion in psychiatric disorder as well as in schizophrenia is delusion of persecution. But any delusion can be seen in schizophrenia. Another symptom is hallucination. Again, any type of hallucination can be seen, but most common hallucination is auditory hallucinations. Now, let's talk about negative symptoms in schizophrenia. And before that, in fact, positive symptoms of schizophrenia, it has been seen that there are two important dopamine pathways implicated in the development of these symptoms. So one is the mesolimbic pathway. In the mesolimbic dopamine pathway, it is seen that there is an increase in dopamine which leads to development of positive symptoms. Now, when we talk about negative symptoms, it is seen that there is in the mesocortical dopamine pathway, there is a decrease in dopamine that leads to development of these negative symptoms. So what are these negative symptoms? So let us try to remember some of the important negative symptoms from the A's you can remember. One is anhedonia. We've discussed there is decrease in the interest. Then next is avolition. Volition is will. So avolition is decrease in the will or drive. So family members may say, sir, it seems that he has lost his will power or drive to do things. We tell him to do things, but he does not show any will or motivation. Then affective blunting, we have discussed flat affect or blunt affect. There is decrease in the expression of emotions. The person is not expressing any emotions. Asociality, again from the name itself, there is decrease in the socialization. So family members may say, we take him outside to meet people, he does not socialize. People come at the home and meet him, he does not socialize. And lastly, alogia. So please remember again, we have discussed neologism. What was logos? Logos means word. So alogia means decrease in the verbal output. So family members say he speaks very less, maybe just few words. Okay. So these are the 5 important negative symptoms. So again, if you see, everything is getting subtracted, getting decreased. That is why they are known as negative symptoms. Okay. Generally we see positive symptoms, they respond well to medicines. So they have good prognosis. Negative symptoms generally do not respond well with medicine, so these are having poor prognosis. Third set of symptoms are disorganized symptoms. So as the name suggests, these patients may have disorganized speech or thought. So we have discussed some of the disorganized symptoms which were included under formal thought disorders. So we discussed in formal thought disorders, there was disorganization. So like loosening of association, neologism, all these are under this. Then person may also have some very disorganized behavior, very, very bizarre behaviors may, person may, tear his clothes and, walk like this on the street. So very bizarre behaviors may be there. And also inappropriate affect may be there. So affect of the patient is not appropriate with the situation. So suppose the person goes in a funeral and starts laughing. So the affect may be inappropriate according to the situation. So such disorganized symptoms may be seen. Another set of symptoms which may be seen in the patient are the catatonic symptoms or motor symptoms. Okay, so there are many catatonic symptoms. Let's try to understand, very important to understand these catatonic symptoms. So we'll try to club them together so that it becomes easy for us to remember. So let us discuss the first 3 catatonic symptoms. One is stupor. Again, stupor means extremely hyperactive or immobility. So person's activity levels are very, very low. So person is just lying down and not moving much, not reacting much. So person may be in a state of stupor. Then another is excitement. Some patients may be in a very hyper excited state. There is extreme hyperactivity, non-goal directed activity. They're just moving around doing things. So their activity levels are very, very high. Then third is mutism. So just like you can mute a television, as if you muted the patient. So person is moving, doing things, but there is no or very little verbal output or response. So that is mutism. Now next two, let us try to discuss them together. So next two, one is catalepsy and the other is posturing. Please remember it is catalepsy. There is another symptom known as cataplexy, which we will see in narcolepsy. So in narcolepsy, we don't have catalepsy. So you can remember it like this. Catalepsy is seen in catatonia. Both of them are basically odd postures maintained by the patient for a long duration, as you can see in the image. Since, the difference is the catalepsy is a passive phenomena. So let us say the person has himself, not made this posture, but a person has made the patient stand like this. And then now the patient is maintaining the posture. This is catalepsy. While posturing is when the person himself has stood in this posture and is now maintaining it for a long time. Then we call it as posturing. So both of them are similar. So, but the difference is one is passive, one is active. Now, next is waxy flexibility. So what is waxy flexibility? As the name suggests, person can be molded like a wax candle. So, when you try to mold a wax candle, there is initial resistance and then you can mold the candle the way you want. Similarly, when you try to move the patient, there is initial resistance. Thereafter, you can mold the patient the way you want. So this is waxy flexibility. This is a sign which we can demonstrate in the patient. Now, let us try to understand the next two symptoms together. One is negativism and the other is automatic obedience. So the name will tell you the symptoms. So negativism is as if the person has developed a negative attitude. So the patient is either giving no response or is opposing to the examiner's instructions. So suppose you tell the patient to come forward. Either the patient is showing no response, so he's standing on his place, or he's going backwards. So he's doing the opposite. So this is negativism. What is automatic obedience? As the name suggests, here the person is becoming excessive cooperative. There is excessive cooperation shown. Automatically now he's become obedient. So tell him whatever you want to tell him, he will do that, even if it harms him. So let us say you tell him that there is a needle in my hand and I'll prick your tongue with the needle. And you now tell the person to pull out the tongue. So he'll pull out the tongue. And you slightly, if you just prick it with the needle, again you tell him to pull out the tongue. Again he will pull out the tongue. So this is extreme cooperation, automatic obedience. Now again, next two, let's discuss them together, mannerisms and stereotypy. So both of them are repetitive odd movements. Again, the difference of person is doing some movements which are now become very repetitive, very odd. But again, the difference you can remember from the name itself, mannerisms have some manner. There is a purpose. So although now they become very odd, but these movement had a purpose. So for example, like this. So person is doing like this. So these are salute movement, but now the person is doing it repeatedly. Now it has become mannerism. While stereotypy, again, these are repetitive movements, but these are non-purposeful movements. So many times person, may do these midline movements. Again, we'll discuss it when we'll talk about Rett syndrome. Such midline stereotypic movements the person may do. So these are, again, there is no purpose in these movements. Now, next two again, echolalia, echopraxia. What is echo or echo? It means to repeat. So echolalia, you can see, echo means to repeat, lalia means word. So person is repeating the words, which are spoken by people around or by the examiner. So suppose you ask the patient, what is your name? Patient will say, what is your name? What do you do? What do you do? Where do you live? Where do you live? So this is echolalia. Whatever you say, the person will repeat it. What is echopraxia? Praxia means movement. So what is echopraxia? Echopraxia means repeating the actions or movement. Suppose you, with a pen and paper, are writing something in front of the patient. Now the patient does not have any pen, any paper, but he is also making this movement. So this is echopraxia. Now coming to the last two of the catatonic symptoms. So one is grimacing. So what is grimacing? Nowadays when you take a selfie, what do? You pout. And if you maintain it for a long time, that is grimacing. Maintaining odd facial expressions. And last is ambitendency. So please remember, ambivalence was when the person was not able to decide in the thinking. Ambitendency is when the person is not able to decide a movement. So for example, there is a pen on the table and you're putting your head forward, then backward, then forward, then backward. So you are stuck. You're not able to decide whether I should pick it up or not. So when you're stuck at the movement level, then it is ambitendency. So these are some of the important catatonic symptoms. So we say generally if a person has 3 or more of these catatonic symptoms, then we say the patient is having catatonia. Okay. Now let's come to the diagnosis now. So these are the 5 important symptoms again according to DSM-5. So if you see all these 5 symptoms we have discussed: delusions, hallucination, disorganized speech, grossly disorganized or catatonic symptoms, and negative symptoms. Okay, these are the symptoms of schizophrenia. So how do we make a diagnosis? So you can remember it like this. So according to DSM-5, so please remember 2 or more of the symptoms should be present. So at least 2 symptoms out of these 5 should be present. But there is a catch. at least one symptom should be from the first three. At least one symptom should be, if there are at least two symptoms, one should be from first three, and these should be continuously present for at least 1 month, but the disturbance should be for at least 6 months. So maybe these symptoms may not be present throughout these 6 months, but at least 1 month these symptoms are present, and in between those 6 months, some or the other disturbance like irritability, sleep disturbance, or milder form of these symptoms may be present. So total duration of 6 months. So please remember, we take this duration as 6 months for making a diagnosis of schizophrenia according to DSM-5. Okay, so this is how we make the diagnosis. Again, if you want to remember a trick, you can remember it with the mnemonic dhadkan, DHA dhadkan. This is how also you can remember the symptoms. According to ICD-11, the duration is 1 month. So suppose, let us say there is a patient, since 8 months, he is suspecting that neighbor wants to kill me, and is also hearing their voices when he is sitting in his room. Nobody else can hear their voices since 8 months. So he's suspecting neighbor wants to kill me is delusion of persecution. So any delusion can occur, and is also hearing their voices when no one other can hear. That is, it is hallucination. So two symptoms are there, and both the symptoms are actually from the first three. So one should be from first three. So yes, it is fulfilling, and duration is more than 6 months. Diagnosis is schizophrenia. Okay. So this is how we make the diagnosis of schizophrenia. Now, earlier there were also some subtypes. We'll discuss them briefly when we talk about the prognosis. But please remember those subtypes. So when we make a diagnosis of schizophrenia, after which we could subtype it like paranoid or catatonic now. So those were present in earlier classifications like ICD-10, DSM-4, but now those have been removed. Those have been removed from the newer classification. Both DSM-5 and ICD-11 now have removed those subtypings. Now ICD-11 now classifies schizophrenia based on the course of the illness. So it says if it's a first episode, so then say it's the first time when the symptoms are developed, it is schizophrenia first episode. It may be multiple episode. Multiple episode means symptoms had occurred earlier and there was a total remission, patient had recovered, and now there is another episode. So 2 or more episodes, then we say it is multiple episode, and some patients may have schizophrenia continuously. So if the symptoms are continuously present now, for at least 1 year, then we say the course is continuous. So based on the course, ICD-11 have, and in fact DSM-5 have divided. Now ICD-11 also has made in fact a separate diagnosis for catatonia. Now please understand, catatonic symptoms are not just seen in schizophrenia, but they can be seen in many conditions, even in mood disorders. But now they made a separate diagnosis of catatonia. So suppose someone has catatonic symptoms, so we say that patient is having catatonia, and it may be associated with some another mental disorder, or it may be associated by some substance induced, or it may be unspecified. So it has been made into a separate category of diagnosis. Also, please remember, when we'll talk about treatment of schizophrenia, we'll talk about the treatment is by antipsychotics. But when we talk about catatonic predominant schizophrenia, that is catatonic schizophrenia, in which the catatonic symptoms are predominant, in that the treatment, the first line treatment is lorazepam. Very, very important is lorazepam, and also ECT may also be used. So in the treatment of catatonic symptoms, we give lorazepam. Initially we give parenterally, and gradually we can shift to oral. And if it not work, or we cannot give it more, then ECT may also be used. So this is the treatment of catatonic symptoms. Now, if we talk about suicide in schizophrenia, now most common cause of premature death in a patient with schizophrenia is suicide, and the rate of suicide is around 5 to 6%. Earlier studies used to say it is 10%. It is around 5 to 6%, and 20% of the patient attempt suicide. And when we talk about completed suicide, it is in 5 to 6% of the patients. Now, let's talk about prognosis factor. So again, there can be good prognostic factors. So good prognostic factor means the outcome is good, or it can be poor prognostic factors. So let us talk about some of these prognostic factors. So some of the good prognostic factors is based on the onset. When we say the symptoms are acute or sudden, abrupt onset, it has good prognosis. So suppose someone is having schizophrenia since 8 months, and family members say that when it started, all the symptoms started within few days or within 2 weeks, then we say it is acute onset. So it has a good prognosis in compared to someone, let us say family members say the symptoms had started few years back. There were some symptoms of irritability, decreased, even gradually the symptoms, they came. So insidious onset, slow onset, we say it has poor prognosis. Now based on the age of the person when they had an onset, so if someone develops schizophrenia at a later age, we say it is good prognosis compared to someone who develops schizophrenia at an earlier age. That is poor prognosis. Now coming to the subtypes, again, there are some important subtypes we can discuss. So catatonic schizophrenia, it is said to have one of the good prognosis. Catatonic schizophrenia has, seemed to have good. In fact, it is one of the subtype which has the best prognosis. So there are predominant catatonic symptoms. Again, even paranoid schizophrenia, in paranoid schizophrenia, there are predominant delusions and hallucination. It has also good prognosis. While if we compare it with schizophrenia, that is simple schizophrenia, in simple schizophrenia, there are predominant negative symptoms. It has the worst prognosis. Even hebephrenic or disorganized schizophrenia, where there are predominant disorganized symptoms, also have bad prognosis. So based on the subtypes also, we can differentiate good prognosis or bad prognosis, and we have discussed these subtypes have been now removed. Again, based on the gender, we have discussed females have a good prognosis compared to males who have bad prognosis. Prominent positive symptoms, again, we have discussed it carries a good prognosis, while prominent negative symptoms, like in simple schizophrenia, there are predominant negative symptoms, it has poor prognosis or bad prognosis. Now, these two again are important. Please remember, presence of mood symptoms. Suppose patient has schizophrenia and patient also appears to be, let us say, sad. So there are some mood symptoms also present. So we say if the mood symptoms are present, it is good prognosis as compared to someone who has absence of mood symptoms. So again, we've discussed the affect is very flat. So somebody does not have mood symptoms. That means again, it very seems to be very severe. So mood symptoms are still present. That means the mood is still, mood is still there. So you can remember it like this for your, ease of remembrance. You can remember it like this. So presence of mood symptom is a good prognosis. Similarly, a family history of mood disorder is a good prognosis. So somebody has schizophrenia and let us say the mother has depression or father has bipolar disorder. It carries a better prognosis as compared to someone who has schizophrenia and in the family, let us say the brother is having schizophrenia or father is having schizophrenia. So in compared to that, family history of mood disorder is a good prognosis. So again, you can remember if a lot of family history, there maybe genetic loading is more. So again, it seems to be having a poor prognosis. So these two please remember because sometimes we get confused. Now again, somebody who's married is a good prognostic factor as compared to someone who's unmarried or he's divorced. So again, social support is there. Again, it seems to be a good prognostic factor. So good social support, good prognosis, poor social support, poor prognosis. Good pre-morbid functioning. Pre means earlier, functioning. Pre-morbid means illness. So before the development of illness, how was the functioning of the person? So suppose someone was very good in functioning, he was doing all the work regularly. So we say it carries a good prognosis. While someone even before the illness was very lazy, was not doing work properly, functioning was not, proper. So again, it carries poor prognosis. If someone is employed, it is good prognosis. Unemployed is a poor prognostic factor. If there is a precipitating factor, suppose after some event, let us say there was a financial loss, after which person develops schizophrenia, it has a good prognosis as compared to someone who did not have any precipitating factor but just developed schizophrenia. So these are some of the good and bad prognostic factors in schizophrenia. Now coming to the treatment, let us talk about the treatment. So we use antipsychotics, also known as neuroleptics. So we have two classes of antipsychotic, the first generation or the typical antipsychotics and second generation or the atypical antipsychotics. So differences in the mechanism. So we have discussed there is increase in dopamine in patients with schizophrenia. So what is the mechanism of action? They are D2. D2 is one of the dopamine receptors, D2 antagonist. So always try to correlate the mechanism with the etiology. It becomes very easy. We've also discussed that other neurotransmitters like serotonin are also affected. So second generation are D2 as well as 5-HT2A. So both are 2 you can remember and A you can remember with the atypical. So D2 and 5-HT2A antagonist. So they are antagonizing both dopamine and serotonin. Generally, EPS or extrapyramidal symptoms, we'll talk about those side effects, are more with first generation because they occur because of D2 blockage, and D2 blockage is more with the first generation, while less EPS with the second generation. And when you talk about the metabolic side effects like weight gain, hypertension, diabetes, hyperlipidemia, these are more with second generation because it occurs because of the antagonism or because of various other neurotransmitters involved. So it is more with second generation as compared to the first generation. Now it is seen again positive symptoms may be taken care by the first generation, while negative symptoms and positive symptoms both may be taken care by the second generation antipsychotics. Now let's talk about some side effects with antipsychotics. So first is the mood disorders, also known as extrapyramidal symptoms or EPS. They occur, as we discussed, because of D2 receptors blockage in the nigrostriatal pathway. So because dopamine is getting blocked, it is also getting blocked in this pathway. It leads to these extrapyramidal symptoms. It is more with typical antipsychotics, especially who are having high potency as compared to the atypical antipsychotics. So you can remember various extrapyramidal symptoms with the mnemonic DP at night. So dance party at night. So you can remember with this mnemonic DP at night. So there is acute dystonia, drug-induced Parkinsonism, akathisia, tardive dyskinesia, and neuroleptic malignant syndrome. Okay, so we can remember it with this mnemonic. So let's talk about first dystonia, acute dystonia. The onset is earliest. So especially, in fact, if you give parenterally you give IV or IM, it may develop even in minutes. Okay, so there is sudden muscle contraction. So person may present with eyes rolling upwards. There may be oculogyric crisis. So patient comes with eyes up, he's not able to move them down. So sudden contraction of muscles. So the neck muscles may be twisted. So torticollis may be seen, or their jaw muscles, there may be trismus, or even laryngospasm occur. So sudden onset. So it is one of the earliest. Again, treatment is parenteral anticholinergic drugs you can give like benztropine, and even promethazine can be given. First is acute dystonia. Second is drug-induced Parkinsonism. It may occur, it may have an onset after days or weeks of prescribing the antipsychotics. So Parkinsonism like symptoms such as tremors, there may be rigidity, bradykinesia, and at times there may be rabbit syndrome, perioral movements, midline vertical movements like a rabbit may be seen, and these usually occur at later stage. So what is the treatment of drug-induced Parkinsonism? Anticholinergic drugs like benztropine, diphenhydramine, trihexyphenidyl. These are the drugs which are used. Then akathisia. So akathisia, it is the most common EPS. First, it's the most common EPS. So akathisia basically means restlessness. So there is first is subjective restlessness. Person is saying, I'm feeling restless. And also objectively also we can see signs. So there may be rocking, motion while the person is sitting, or the person may be spacing around, or, person may be doing, movements like this. He's, hopping on, alternate feet. So there is again the restlessness may be seen objectively. This is akathisia. Now treatment is, we use beta blockers like propranolol. These are the drug of choice for akathisia. Next is tardive dyskinesia. Tardive means late onset. So it occurs slightly late. So maybe months of treatment. And dyskinesia means abnormal movements. The cause is basically there is supersensitization of the D2 receptor. So because of chronic blockage, there may be supersensitization of these receptors. Now again, these patients may have involuntary movements like lip smacking or chewing movement, or there may be tongue protrusion movement like fly catching, or coriform hand movement like piano playing movement. Such movements or pelvic thrusting movements may be there in these patients. Now treatment is, one of the drug which is approved is valbenazine. Another drug which can be used is tetrabenazine. These are basically, they inhibit the vesicular monoamine transporter 2. So basically these are dopamine depleters. Of course, we should also reduce the drug or stop the offending drug, and sometimes we can switch to drugs which have less EPS like clozapine or other atypical antipsychotics. Lastly, there is neuroleptic malignant syndrome. As the name suggests, malignant, it is a life-threatening complication. So person on antipsychotic may present with fever, rigidity, there is increased creatine phosphokinase, CPK levels are increased. Along with this symptoms like tachycardia, sweating, leukocytosis, so WBC count has been raised, altered consciousness, so there is impaired consciousness, increased level of liver enzymes will also be there. So now treatment is, one, we have to stop the drug, give supportive care like maintain hydration, and the drug of choice is dantrolene, which is a skeletal muscle relaxant. It is the drug of choice, and of course we can also use certain dopamine agonists like bromocriptine, amantadine. Drug of choice is dantrolene for NMS. Another side effect of antipsychotic which can occur are the endocrinal side effects. Now these occur because of blockage of the D2 receptor in the tuberoinfundibular pathway. So they basically occur from the pathway from the hypothalamus to the anterior pituitary gland. So this leads to hyperprolactinemia. So dopamine blockage in this pathway. So dopamine and prolactin have an inverse relation. So it leads to increase in the prolactin levels. So In both males and females, there may be sexual side effects like decreased libido, and in females there may be other side effects such as galactorrhea, that is milk secretion, and even amenorrhea, cessation of menses, which occur because of blockage of dopamine in this pathway. Now, in the typical or the first generation antipsychotics, so again, high potency drugs like haloperidol, they block D2 receptors, okay, which can cause side effects like EPS and endocrinal side effects. While low potency drugs which have low potency for D2 receptors like chlorpromazine, they may also have other side effects because of blockage of muscarinic receptors, so they may cause anticholinergic side effects. Alpha-1 blockage can cause hypotension, orthostatic hypertension. Then H1 blockage, histaminic blockage can cause sedation. So these may occur with some low potency drugs as well. So side effects may occur based on what receptors are getting blocked. Let us discuss some of the important common medicines like chlorpromazine. So chlorpromazine, it has the side effect, anticholinergic activity side effect is very high. Then C for chlorpromazine, it can also cause corneal and lenticular deposits in the eye. It may also cause photosensitivity, as well as cholestatic jaundice may also occur with chlorpromazine. Haloperidol is one of the drugs with highest of D2 potency, so one of the drugs with highest EPS. Thioridazine, again there is R, it can cause retinal pigmentation, which is irreversible. Cardiac arrhythmias can also occur, there is increase in the QTC prolongation. It is one of the drugs with least of EPS. Penfluridol, it is one of the longest acting antipsychotics, so it can also be given as weekly medicines. So these are some of the drugs in the typical. Then in the atypical or the second generation, as we have discussed, they block D2 and 5-HT2A, less EPS, and again they can also cause less hyperprolactinemia is there. Metabolic side effects are more, like weight gain, diabetes, hyperlipidemia, hypertension, cardiovascular diseases are more with these. Now olanzapine can also cause weight gain, one of the drugs known to cause weight gain. Now risperidone is one of the second generation, but it has, it causes high levels of EPS. So one of the second generation with high EPS is risperidone. It also can cause hyperprolactinemia, and same with amisulpride. So risperidone is one of the second generation antipsychotic with one of the highest EPS potential. Then ziprasidone, it can increase the QTC interval. Aripiprazole, now mechanism of action is again, it has slightly different, that it's a partial agonist at D2. It is also antagonist at D2, 5-HT2A, but it's a partial agonist at D2. Similarly, brexpiprazole also is a partial agonist at D2. Okay, and even cariprazine has also partial agonist at D2 and also other receptors. So these are some of the newer antipsychotics. Then pimavanserin, again a different mechanism of action. Pimavanserin, you can remember, serine, it is serotonin, so 5-HT. So and it has two A's in the name, so 2A, 5-HT2A inverse agonist. So serine is, the name is telling you serotonin inverse, so inverse agonist at 5-HT2A. Now it is one of the drugs which is approved for treatment of delusions and hallucinations in Parkinson's disease. So Parkinson's disease, already the person is having a lot of these motor symptoms, and we have seen that antipsychotics can cause EPS. So this is one drug which is approved for this condition. Okay, it does not cause EPS. Also even clozapine is also one of the drugs with least EPS can be used. But this is a drug which is approved for this condition. One has to be careful, and it can increase the QT interval. Now let's talk about clozapine. Clozapine is a second generation antipsychotic. Some important points about it. Now it is antagonist at more at D4 than D2, and it is one of the drugs with least of EPS. It is the only antipsychotic with anti-suicidal property, and it is used for only one condition, that is treatment-resistant schizophrenia. So what is treatment-resistant schizophrenia? That means, so if the patient has not shown improvement to at least 2 different categories of antipsychotics given at adequate duration and dose, then we think of clozapine. So clozapine should not be started in a person who has never been started on any antipsychotic, because it has some serious side effects. So only for those treatment resistant cases we use clozapine. Now it has side effects. Most common side effect is sedation, and weight gain is, out of all the antipsychotics, maximum weight gain is by clozapine. Now some of the serious side effects, why we use only for treatment resistant and not for every patient. So you can remember with this mnemonic SAM. One is seizures. Seizure, it can occur and it is dose dependent. Second is agranulocytosis. There is a decrease in the TLC count, the WBC count, as well as especially the neutrophil count. So when we start any patient with clozapine, weekly monitor for first 6 months, we have to do the WBC count, and that has to be done. And generally we stop it if the WBC count is less than 3000 per millimeter cube, and the ANC count is less than 1500 millimeter cube. So a patient on clozapine comes to you with fever, sore throat, patient may have agranulocytosis. So stop the clozapine. And it can also cause myocarditis, SAM. So patient on clozapine complaining of chest pain, tachycardia, take a ECG. So patient may be having myocarditis. So the last two symptoms, agranulocytosis and myocarditis, these are idiosyncratic. They are not dose dependent. Now, some of the contraindication, one, as we know, if the WBC count is less than 3500, don't start clozapine. If there is a previous bone marrow disorder, then also, if there is a history of agranulocytosis during clozapine, again. Now, use of another bone marrow suppressant drug like carbamazepine, again, that should be avoided. So never combine. So we have discussed, it causes seizure. So when someone develops seizure, we can give anti-epileptic drug, but which one anti-epileptic drug you should not give with clozapine is carbamazepine. Okay. We also use long-acting injectables, LAI antipsychotics or depot antipsychotics. So basically these are intramuscular injections which are given by weekly or monthly or sometimes even longer. So we give it, and then you have to repeat it after 2 weeks or maybe 1 month. So the drug is getting released slowly in the body. So there is a maintenance of the level in the body for some time. Now basically, especially these are used who are show poor compliance, they don't take medications properly. In those patients especially, we can use these depot preparations. And in fact, there is a method technique by which we give depot injections. So basically it's known as Z-track technique. So we pull the skin and then we put the needle and then we inject and then we release. So there is a Z-like track it occurs so that the drug is not oozed out back to the root. So to prevent the tracking or leaking of the drug, we use this technique for depot preparations. Now we've talked about schizophrenia. Let's talk about some other psychotic disorders. First is acute psychotic disorder. Here the symptoms, as the name suggests, acute. So symptoms are similar to schizophrenia, but the duration is not meeting the duration criteria for schizophrenia. So acute means less duration. So symptoms like delusions, hallucination, disorganized symptoms are there, but the duration is not fulfilled. Then we say it is acute psychosis. So let us say for 15 days someone is having delusions and hallucinations. We cannot make the diagnosis of schizophrenia, so this is acute psychosis. And usually they have abrupt onset and they also resolve, often completely. Now they may be precipitated by or preceded by some stressor. So there may be some life event like, let us say there was death of someone, or there was a breakup, or there was some financial loss, after which the person developed acute psychosis, and sometimes even fever may be there. Now, fever, this is again very important. Sometimes sudden, fever with sudden onset of symptoms like delusions, hallucinations, and abnormal behavior. Again, we can have two differentials. One is acute psychosis and the other is delirium. So delirium is an organic disorder. So again, it also has similar presentation. How to differentiate? Please remember, in delirium, the person would have impairment of consciousness. That is very, very important symptom. We'll talk about it in organic mental disorder. So if the impairment of consciousness is not given, then it is acute psychosis. Okay. So again, because fever is there, you may think of organic cause. So again, you should also remember that in acute psychosis also fever may occur. In ICD-11, so duration of schizophrenia is 1 month. So if it is less than 1 month, it is known as acute and transient psychotic disorder. While in DSM-5, the duration for schizophrenia is 6 months. So less than 1 month, if someone has symptoms, it is known as brief psychotic disorder. More than 1 month, but less than 6 months, it is known as schizophreniform disorder. Treatment is with antipsychotics. Next is schizoaffective disorder. So as the name suggests, schizo, there is presence of schizophrenia symptoms, affective mood symptoms together. And both the symptoms are present for the majority of the time during the illness. Now please remember, even in schizophrenia, mood symptoms can occur, but they are not occurring throughout the course of illness. Even in mood disorders, psychotic symptoms can occur, but they are not occurring throughout the course of illness. So schizoaffective disorder is when the symptoms are occurring throughout. Both the symptoms are occurring most part of the illness. So let us say someone has schizophrenia symptoms for 1 year and also similar symptoms for nearly 1 year. But we say there may be 2 weeks period in which patient just have delusions and hallucinations. Rest all that 1 year, the patient have both the symptoms together, it is schizoaffective disorder. It has two subtypes, bipolar type when patient has manic symptoms and depressive type when patient have depressive symptoms. So again, treatment will also change because like if patient has bipolar type, so along with antipsychotic, mood stabilizer may be added. If depressive symptoms are there, antidepressant may also be added with antipsychotics. Now if we talk about the prognosis, we say generally prognosis of schizoaffective disorder is better than schizophrenia because again it is also having mood symptoms, so it is better prognosis than schizophrenia. And last is delusional disorder. Now in delusional disorder, as the name suggests, one or more delusions are there which may be usually related and they're persistent. So let us say someone is having suspiciousness that neighbor wants to kill me. This is delusion of persecution. Also has this suspiciousness that they are talking about me. This is delusion of reference. Also have a delusion that wife is having an affair with the neighbor. This is delusion of infidelity. So they may be related in this manner. So patient may have one or more delusions. Sometimes they may not be related. They're persistent. So if person has only delusion, can we make a diagnosis of schizophrenia? No. For schizophrenia, at least two symptoms should be there. So then the diagnosis is delusional disorder. Now also please remember, hallucinations are usually absent. If they are present, they are not prominent or they are very transient. They occur for short duration. If the hallucinations are also occurring for some time, long time, then the diagnosis will change because now hallucinations are also occurring persistently. Now, very important is that, when we talk about delusional disorder, the functioning of the patient is not markedly impaired. So functioning wise, the patient is normal in all the other areas which are not affected by delusion. So for example, in this case, the person is going to his office regularly, is meeting people. It's just that he's not, meeting the neighbor and maybe avoiding the neighbor. In that area, his functioning may be affected, but all the other areas, the functioning is normal. So this is again an important point which differentiates it from schizophrenia. In schizophrenia, there is, severe impairment of functioning. Here, the functioning is maintained. Again, treatment is with antipsychotics. Now let's talk about mood disorders. So mood disorders are also known as affective disorders, and as the name suggests, there is abnormality of mood. So mood disorders, broadly we can classify into depressive disorders and bipolar disorder. As you can see from the diagram, in depression, the mood is always on the lower side. Okay, if the upper pole represents happy or elated mood and the lower pole, it represents low mood. So in depression, the episodes are always on the lower pole. So it may be just one episode or it may be multiple. And in between, you can see the person becomes absolutely normal. So these are basically episodic type of illnesses. While when you talk about bipolar disorder, if you see, the mood is sometimes on the lower pole and sometimes on the higher pole, wherein the patient may have episodes of mania or hypomania. So that is why they are known as bipolar disorder. So mood can be present on any of the poles. So these are depressive disorders and bipolar disorders. So let's talk about depression. Depression in DSM-5 is known as major depressive disorder, or you can simply call it as depressive disorder or sometimes unipolar depression, as the depression is occurring only on one pole. Okay, so there are only episodes of depression. So depression, if you talk about epidemiologically wise, depression is the most common mental disorder in India. So according to the National Mental Health Study, it is the most common psychiatric disorder in India. And we talk about the world, we say as a group, anxiety disorders are the most common psychiatric disorder. And in that, if you're asked which is the individual most common psychiatric disorder, that will be specific phobia. Depression is the second most common. Now, depression is more common in females than male. The ratio is 2:1. And the mean age of onset is around 40 years. So it is, most common in middle-aged females. But yes, of course, it can occur even in young age and even in elderly. Maximum dailies, that is disability adjusted life years out of all the psychiatric illness is depression. Now let's talk about the etiology again. Multiple factors are there. Now in the biological factors, first very important is the neurotransmitters. So there is a monoamine hypothesis. So various monoamines are implicated in development of depression, and two very important monoamines are serotonin and norepinephrine. So both serotonin and norepinephrine are decreased, and even dopamine is also decreased, but you have to choose two when it is serotonin and norepinephrine. Now even endocrinal disturbances can also lead to or are implicated in depression, especially hypothyroidism. So hypothyroidism may be associated with depression, and in fact, in the treatment sometimes along with antidepressants, so we use antidepressant in the pharmacotherapy, we may also sometimes use thyroxine as an augmenting agent. Person may not be having clinical hypothyroidism, but it is seen sometimes giving thyroxine or augmenting antidepressant with thyroxine improves the symptoms. So this is again important. Now in the psychological theories, one important theory is the cognitive theory. So cognitive theory is for depression, given by Aaron Beck. So basically Aaron Beck postulated that depression develops because of cognitive distortions. So cognitive distortion means negative, inaccurate ways of thinking. So all of us have automatic thoughts which occur in our mind, but person with depression, they have automatic negative thoughts. So there is some inaccurate ways of thinking which occur in these patients, which is the psychological theory or the cognitive theory of depression. Also, there is a cognitive triad given by Aaron Beck of depression. So what this triad says, so a person with depression develop negative views about themselves. So person may believe that he's a bad person, I'm a bad father, I'm a bad son, I'm a bad husband. Such kind of negative, beliefs or thoughts about self may occur. So this is known as, so I am worth nothing, worthlessness. Okay. Then there may be negative views about the environment, that environment is very harsh, nobody, is helping me, nobody can help me. So there is helplessness. Or there may be negative views about the future. So patient may have these thoughts that future is going to be very bad, that everything is very bleak, everything is very dark, there is no hope in the future. So hopelessness. So worthlessness, helplessness and hopelessness. Now let's talk about the symptoms of depression. So symptoms of depression you can remember with the mnemonic SIGE CAPS. So you can remember with the mnemonic SIGE CAPS. So let us understand these symptoms. First is S, that is sad or depressed mood. So person have a sad or depressed mood which is persistent and pervasive. Then I is interest. What happens to the interest? There is decrease in interest, and we have discussed what it is known as anhedonia. So if you see now, anhedonia is one of the symptoms of depression. Then G is excess feelings of guilt or worthlessness. So patient may have these feelings, that I'm a very bad person, or I'm a sinner, or I'm worth nothing. So such types of feelings, such types of thoughts may occur. Then E is energy. So what happens to the energy in a patient with depression? There is decrease in energy. So patient get tired very easily, or there is easy fatigability. So patient may say that, I do just half the work which I used to do previously, now I get tired. Sometimes just by sitting I get tired. So there is decrease in energy. This is SIGE. Then C is concentration. So patient often say that, there is a decrease in concentration. I'm not able to concentrate. So, what symptom they may develop? They may report of forgetfulness. So person may say, that I forget where I keep important documents. Even while talking, I forget what was being talked about. So this forgetfulness, or this is not, true dementia, or this is not true memory loss. This is because of decrease in concentration. So this is also termed as pseudo dementia. So let's try to correlate some of the points in these symptoms itself. Then A is appetite. So again, many of the patients with depression would report of decrease in appetite, and subsequently there will be a decrease in the weight. While some patients, so normally they say there is decrease in appetite and decrease in the weight, and significant weight changes when it is more than 5% in a month. While some patients, small set of patients may also say that, the appetite has increased, and subsequently what happens? There may be weight gain. So this may be decrease or it may increase. Then P is psychomotor activity. Psycho means psychic, mind, motor means body. So the activities of the mind and the body, there may be decrease. So there may be psychomotor retardation. So person may move very slowly, talk very slowly. But sometimes you may find patient with depression, they're very restless, not able to sit. So it may even increase. So psychomotor agitation. S is again very important. Suicidal thoughts or acts may occur. Again, very important. We need to, we need to be very cautious, if the person develops suicidal thoughts or may even attempt suicide. And lastly, sleep. So what happens to the sleep again? Many of the patients report of there is a decrease in the sleep. They say, I'm not able to sleep. So this is known as insomnia. In fact, one specific insomnia may be seen in many patients, which is early morning insomnia. So many patients may complain that, they wake up at least 2 hours before their normal time. So if previously they would wake up at 8 o'clock in the morning, now they say that they wake up before 6 o'clock in the morning. So early morning insomnia may be seen in these patients. And sleep may also increase. So many patients may also report that they are sleeping excessively. Even during the daytime they are sleeping. So there may also be hypersomnia. So these are the symptoms which may be seen in depression. So let us understand the diagnostic criteria. So again, according to DSM-5, at least 5 or more symptoms should be present, and at least one of those 5 symptoms should be from the first two. That is the mood is sad or depressed and there is decreased interest, that is anhedonia. At least one of the symptoms should be present along with this 4 or more symptoms, and the duration, if they're present for at least 2 weeks, 14 days, then we say the patient is having depression. So for example, a patient reports of feeling sad, most part of the day, most time of the day, most of the places, there is decreased interest, reports of low energy, forgetfulness, wakes up 2 hours before the usual time, crying excessively, and all these symptoms have been present since 2 months, so the diagnosis is depression. Now, then there is something known as recurrent depressive disorder. What is recurrent depressive disorder? So as the name suggests, when there are 2 or more episodes of depression. So suppose a patient comes to us with this episode of feeling sad, decreased interest, and when you take a history, it seems that some time back the patient had a similar episode. So now when the patient is presented to us, that means this is a second episode. Patient already had a first episode. So now this will be a recurrent depressive disorder. And the minimum duration of normalcy between the 2 episodes should be at least 2 months. Then we say it's a separate or an independent episode. Now let's talk about some important specifiers. So what happens is, suppose we made a diagnosis of depression. Some patients may have certain unique characteristics which we add as a specifier. So we say depression with whatever features may be present with the patient. So depression with whatever features are present with the patient. So let's talk about some of the important specifiers. The first is depression with psychotic features. So patient along with depression may also develop delusions and hallucinations. This is known as psychotic depression. So please remember, but psychotic symptoms, first of all, they develop after the development of mood symptoms, and the mood symptom, depressive symptoms are predominant, and for less duration even delusions and hallucination may occur. So patient may say that neighbors want to kill me, they think I'm a bad person, or he's hearing voices planning to kill him. So delusions, hallucinations, again these can be mood congruent, psychotic symptoms, that means they are in sync with the themes of depression, or they may be mood incongruent. So a patient with depression, let us say, is reporting that I am the king of the world. So depression patient having delusions of grandiosity. So they may be even mood incongruent. Okay. So psychotic symptoms may be present. And what is the important point here is, again, when we add a specifier like this, it also changes the management. So along with antidepressant, now we also have to give antipsychotics. Second is depression with melancholic features, or melancholic features are basically involutional melancholia or melancholic depression. These are basically represent severe form of depression. Now usually seen in old age, but of course it can be seen even in younger age group. So what are these melancholic features? They are more severe form of depression. So patient may report of loss of pleasure nearly in all activities, or there may be lack of reactivity. Even in pleasurable stimuli, the patient is hardly reactive. So normally, let us say a depressive patient might react somewhat, but here the patient shows no reactivity. Now a distinct quality of depressed mood, they say that there is profound despondency, despair, or my mood is very severe, it's an empty mood. Such kind of mood they describe. Now in the morning they may report of early morning awakening, as well as the mood may be worse in the morning, and there may be weight loss, anorexia. The biological symptoms like sleep, appetite, they are significantly affected. There may be excessive guilt. Again, this is important. Many times they give you the symptom, excessive guilt. Maybe at the time a sinner. Excessive guilt may be there, and even psychomotor disturbances may also be associated. So these are representing melancholic features. Again, risk of suicide may be even higher in such patients. So one need to be careful. Next is atypical features. So these have depression along with some features which are not typical of depression. So that is why it is known as atypical features or atypical depression. So you can remember it with the mnemonic. Now, normally, when we talk about a patient having depression, what is the will power of the person? We say generally the will would decrease, motivation would decrease. But the mnemonic, since it is atypical, you can remember it like this. the mnemonic is my will high. Okay, so in atypical, so the mnemonic is my will high. So what are these features? M is mood reactivity. So normally mood may not be reactive, but here the mood is reactive. That means mood brightens in response to any positive event. So suppose patient is having depression, you take him to a party, it's a positive event, so mood may react, becomes brightened, or there is mood reactivity. Then W is, now normally we have discussed the weight usually decreases, but here since it is atypical, there is weight gain as there is increase in the appetite. I is again interesting symptom, that is interpersonal rejection sensitivity. They are sensitive to events and they feel hurt or rejected by others very easily. So they have that interpersonal rejection sensitivity. If someone rejects me in the interpersonal relations, they become very, very sensitive. They get hurt easily. So they have this long-standing pattern. L is laden paralysis. So they report that their limbs, their arms, their legs, they appear very, very heavy, as if they're laden with some heavy weight and they're not able to move. Paralysis. So laden paralysis is seen. And again, H is again normally sleep. What happens to the sleep? The sleep decreases most of the time. But again, since it is again atypical, there is hypersomnia, or there is increase in the sleep. So these are the features of atypical depression. When we talk about the treatment, again, important point to remember is these patients usually respond well to antidepressants like SSRI. We'll talk about SSRIs or MAO inhibitors, even bupropion, but they do not respond to tricyclic antidepressants. So again, it again is affecting our management treatment decisions. Then depression with catatonia. So as we discussed, catatonic symptoms may not just be seen in schizophrenia, it can be seen in other conditions. In fact, they're more common in mood disorders than even schizophrenia. So depression with catatonic symptoms such as waxy flexibility, echolalia, posturing. So patient having depression along with these catatonic symptoms. Again, in the treatment, not just antidepressant, but of course we also have to treat these catatonic symptoms. So you would have to give lorazepam, and sometimes even ECT may be required. So again, it is changing our management, or it is affecting our management. Next is depression with postpartum onset. Postpartum means after delivery. So postpartum depression. So onset of symptoms during pregnancy or within 4 weeks of delivery. Sometimes we say up to 3 months maybe. If within 3 months of the delivery, we may consider it as postpartum depression. Now DSM-5, again it includes it to be during pregnancy and or after delivery. So it is known as peripartum onset. So again, because of a lot of physiological changes, social changes, again depressive symptoms may occur in the pregnancy. Now, when we talk about suicide, 10 to 15% of the patients in depression, they commit suicide, and it is the most common psychiatric disorder associated with suicide. So depression is the most common disorder associated with psychiatric disorder associated with suicide. Now, when we talk about the treatments, so we have two pillars of treatment: pharmacotherapy and psychotherapy. Now, in the pharmacotherapy, we use antidepressants. Usually, these antidepressants takes 3 to 4 weeks for the onset of actions. And usually, we say efficacy-wise, there is not much difference. They're chosen, based on the side effect profile. So, we say the SSRIs, selective serotonin reuptake inhibitors, these are the drug of choice or the antidepressant of choice for depression. Again, because of the safety profile. So drugs like sertraline, fluoxetine, paroxetine, citalopram, escitalopram, vilazodone, fluvoxamine. Fluvoxamine is one of the SSRIs which is not used for depression but for OCD. So these are some of the important SSRIs. Now coming to the side effects, again they have some of the side effects like GI side effects. Nausea is the most common side effect. They may also cause diarrhea, anorexia, dry mouth. Please remember, dry mouth. So they cause dry mouth and not excessive salivation. Constipation may occur, especially with paroxetine because of anticholinergic side effect. Weight gain may be seen. CNS side effects like anxiety. So some patient may report of insomnia. Some patient may have even excessive sedation. Vivid dreams, again, very interesting. Vivid dreams, patient may report of some vivid dreams after taking these SSRIs may be reported by the patients. Now, sexual dysfunction again is important. This is the most common side effect with long-term treatment. So person may report of decreased libido. There may be delayed ejaculation, inhibited orgasm. In fact, this delayed ejaculation, we will use this in treatment of premature ejaculation, wherein we want to increase the ejaculation time. Then certain other side effects like hyponatremia, especially in elderly, may be seen. Then there is vortioxetine. It is a relatively newer antidepressant. It is a serotonin modulator and stimulator. So it affects various receptors. You can remember it like this. It's an agonist at 1A, 5-HT1A, partial agonist at 5-HT1B, antagonist at 5-HT1D, 5-HT3 and 5-HT7. Also, it is a 5-HT serotonin reuptake inhibitor. So along with reuptake inhibitor properties, it has certain other properties as well. Now it is again seen that the sexual side effects may be low. Okay, but again many studies have shown that it may not be, that some sexual side effects may still be there. So relatively comparison wise, they may be low than certain other depressants, but yes, they may be present. So it is marketed as that it is having low sexual side effects. Now, when we take SSRIs, when a female is pregnant, now SSRIs are not major teratogen, but one important drug is an exception. P for paroxetine, P for pregnancy. It should be avoided in pregnancy because of cardiovascular teratogenic effect. Now also SSRIs, is even SNRIs, which we are going to discuss, especially in late part of pregnancy, they can cause persistent pulmonary hypertension of the newborn. Again, so select serotonin norepinephrine reuptake inhibitors, that is SNRI. So they, as the name suggests, they are dual reuptake inhibitors. They inhibit the uptake of both serotonin and norepinephrine. So both serotonin and norepinephrine decreases. So we can correlate with the etiology. So it inhibits the reuptake of both these neurotransmitters. So drugs like venlafaxine, desvenlafaxine, duloxetine, levomilnacipran and milnacipran, these are some of the SNRIs. Now coming to side effects, again they have similar side effects. So even they also cause sexual side effects. Hypertension is one of the side effects, especially with high doses of venlafaxine and also with even desvenlafaxine. Now there is something known as discontinuation syndrome. Discontinuation syndrome, as the name suggests, so abrupt discontinuation of these antidepressants may lead to some withdrawal symptoms like flu-like symptoms. There may be insomnia, nausea, irritability. Such symptoms may be reported, especially it is seen by short-acting drugs such as venlafaxine. And other drugs like paroxetine, even fluvoxamine, they also can cause. So such drugs should not be stopped abruptly and should be gradually tapered and stopped. Then TCS, tricyclic antidepressants and tetracyclic antidepressants, they block the transporters of serotonin and norepinephrine, so increase the levels. Now they also have certain other effects, like they are antagonist at muscarinic receptors. So a lot of anticholinergic side effects they cause, so they should be avoided in person with narrow angle glaucoma. Even histaminic blockage, histaminic receptor H1 blockage is there, alpha-1, alpha-2 and even voltage sensitive sodium channel blockage. So a lot of side effects are seen. That is why they are not very commonly used drug these days. So TCAs like clomipramine, amitriptyline, imipramine, nortriptyline, these are some of the TCAs. Now TCAs toxicity, again so excessive amount of these TCAs can lead to toxicity. So they can have CNS effects like altered sensorium, there can be respiratory depression, CVS like hypotension, lot of ECG changes, QRS complex more than 100 milliseconds, then autonomic nervous system, dry mouth, blurred vision, urinary incontinence. Such effects may be seen in TCA toxicity. So also there is metabolic acidosis is also seen, and so especially when the QRS is more than 100 milliseconds, such patient treatment is IV sodium bicarbonate. So serum alkalization is done. So again it is important. So treatment will be sodium bicarbonate. Then monoamine oxidase inhibitors, MAO inhibitors. These were one of the first class of approved antidepressants. They inhibit the metabolism of monoamines like serotonin, norepinephrine, dopamine. But again, because of side effects, not very commonly used these days. Now let's talk about some atypical antidepressants. So there is norepinephrine dopamine reuptake inhibitor, that is NDRI. Bupropion. Now it has one of the drugs with low risk of sexual dysfunction. So a patient having sexual dysfunction with antidepressants like SSRIs, SNRIs can be switched to bupropion because of one of the drugs with least sexual side effects. One of the side effects which can occur is seizures, especially at higher doses. It is one of the antidepressants which is also used for smoking cessation. So it is used for smoking cessation. Another drug is noradrenergic and specific serotonin antidepressant, which is mirtazapine. Again, mirtazapine is one of the drugs along with bupropion in which the sexual side effects are usually not seen, very less. The side effects which may be seen is sedation, which is one of the most common side effects, and even weight gain can be seen with mirtazapine. Now there is certain novel agents. One of the novel agents is S-ketamine. It is a S enantiomer of ketamine. So mechanism of action is basically an NMDA antagonist, which is a glutamate receptor. It is given through nasal route and it was approved by FDA in 2019 in treatment resistant depression. So treatment resistant depression means if at least 2 antidepressants, give it at adequate duration and dose, not showing much effect, then it can be used along with in conjunction with a oral antidepressant. So this can be used as ketamine. Now, so one was treatment with antidepressants, so another is psychotherapy. So treatment, usually using psychological means. So one of the psychotherapy of choice which is shown to be best evidence for depression is cognitive behavior therapy. So as the name suggests, we use cognitive techniques to correct those cognitive distortions and behavior techniques to correct behavioral problems in the patient, CBT. Now, if we talk about treatment of choice, generally it is seen that combination may have a better response, a higher response, but generally single therapy alone is sufficient for most of the patients. So usually if we talk about, we say, in mild depression, usually CBT is enough, while in moderate to severe depression, then addition of antidepressants become important. Overall, if you have to choose one, then you can go with drugs. Otherwise, a combination generally has shown to have higher response. Then there are certain other methods other than the two we have discussed. So one is electroconvulsive therapy, ECT. So as the name suggests, we use electric current to generate convulsion, seizures in the patient. It is shown to have effects in some of the psychiatric illness. So what are the indications of using ECT in depression? One of the most preferred is when somebody is having depression with suicidal risk. Now please remember, someone is having suicidal thoughts. It's an emergency. Medicines and or therapy may take some time. So usually ECT have a very rapid onset of action. So in such cases, ECT is preferred. And even if, let us say, the patient is pregnant, even then we may give ECT. So it can be given in pregnancy. Also in sometimes when depression with stupor, then again ECT may be given. Now let's talk about bipolar disorder. So what are bipolar disorders? So when person has episodes of mania, hypomania, depression, even mixed episodes. So mixed episode is when person, in one day or in few days, patient is having, sometimes having low symptoms, sad symptoms, and sometimes having happy or related symptoms, irritable symptoms. So it is mixed kind of episode may also occur. In bipolar disorder, there is bipolar 1 disorder, when patient has at least one episode of mania and at least one episode of depression, that we call it as bipolar 1. Bipolar 2 is when patient has hypomania and depressive episodes, and even a single episode of mania now is also considered as a bipolar disorder, both in ICD-11 and DSM-5, that is also under bipolar disorder. So now let us say a patient is having these symptoms as this diagram. So what is the diagnosis? The diagnosis will be depression. Now let us say the patient has another such episode wherein symptoms like sad mood, decreased interest, then again it is RDD, recurrent depressive disorder. Now let us say after some time this patient develops an episode of hypomania. Let us say this is the threshold for hypomania. So this is now, what will be the diagnosis? It will be bipolar 2. At least one episode of depression is there and at least one episode of hypomania. It is bipolar 2, current episode hypomania. Let us say after some time this patient develops a manic episode now. So now the diagnosis will be bipolar 1 disorder. Current episode is mania. So now after this, now any number of episodes of hypomania may occur. The diagnosis will remain bipolar 1 because at least one episode of mania has occurred in the patient, in the timeline of the patient. So this is how we make the diagnosis. Coming to the epidemiology, again the prevalence is 1%. And when we talk about bipolar 1 and bipolar 2, it is seen that the male to female ratio in bipolar 1 is same as in schizophrenia, while in bipolar 2, females more than males, as in depression. Now, genetic factors, again chromosome 18q and 22q have shown to have one of the strongest evidence for development of bipolar disorder, and also 21q is also associated. Now let's talk about the symptoms. So what is the mnemonic to remember the symptoms of mania? The mnemonic is me, dig, fast. So person is doing something very, very fast. So let us understand the symptoms. M is, of course, it's a mood disorder. M is mood. The mood is elated or it is irritable. So person is appearing very, very happy, excessively cheerful. Without any reason, person is laughing. And sometimes the mood may be irritable. Irritable is when the person gets angry on small things. So mood can be elated or can be irritable. Now what happens to the energy? The energy is very, very high. So patient is having excess of energy. You'll say, I can do anything. Very, very high energy levels are there in the patient. D is distractibility. So the person is very, very distractible. So person is talking to you and suddenly there is a noise somewhere. The person, loses the attention and gets easily distracted. So they will not be able to complete the task because they get very easily distracted. I is impulsivity. Again, they will do things out of impulse without considering the consequences. So they may do a lot of overspending. They may do, they may have over socialization. They may go and hug the strangers, as if, they know them. So over socialization, hypersexuality, increase in the sexual activities may be seen, and even they may appear over religious at times. So there is a lot of impulsive activities they may do. Then grandiosity, they may feel, very big of themselves, or there is an inflated self-esteem. The person may go in his office and tell his boss, you get up. I will now, look after the company. I am the boss now. So there is a sense of grandiosity. Then F is, as we discussed in the basics, F is flight of ideas. So the thoughts are moving very, very fast. Okay. So patient speech will also be very, very fast because the thoughts are moving very fast. Activity levels are very, very fast, again increased. So person may try to do many activities at one time. So person may now start doing something, then may just leave it in between, start doing something else. So activity levels are increased. Now sleep, again, very interesting. A 20-year-old male, brought by the family members, and they say, he's not sleeping since 10 days. And, when you talk to him, he say, sleep is a waste of time. I don't require sleep. So there is a decreased need of sleep. And, even if they're sleeping very less, still they would appear very, very energetic. While a patient, who in depression, who is not able to sleep, will tell you, sir, I want to sleep. I'm not able to sleep. But these patients still will appear very, very energetic. So there is a decreased need for sleep. And last T is talkativeness. So they will be excessively talking. Sometimes very difficult to even, make them, stop talking. So these are the symptoms of mania. So the diagnosis is when at least both the two symptoms, that is mood, elated or irritable, as well as energy levels, these two symptoms along with 3 or more of the following symptoms. So again, total of at least 5 symptoms. Duration here is, duration for depression was 2 weeks. Here the duration is 1 week or 7 days. So symptoms present for at least 7 days, then we say the person is having mania. So patient having elated mood, is dancing and singing, excessive energy, and the patient is speaking like this: my name is John, I want an iPhone, going to Rome, stone gone, John Ron. So again, this is what? This is again rhyming. This is flight of ideas. There is a decreased need for sleep and overspending. So these symptoms person comes with, duration for 10 days. So at least 1 week is there. So diagnosis is mania. So this is how patient may present. So again, just like depression, even patients with mania may also have some specified. One of them is mania with psychotic symptoms. So patient has mania. Along with this, patient have delusions or hallucinations. So now, patient is, saying that I'm the king of the world. I can do anything. So there may be delusion of grandiosity. Patient may say that, I'm talking to God. God is directly talking to me. When you talk to God is normal. When God starts talking back again, maybe hallucinations have also started. So again, these may be seen in patients with mania. So this is then mania with psychotic symptoms. Now, then what is hypomania? So as the name suggests, hypo, less than mania. So symptoms are similar to mania, but they are not severe enough to cause marked impairment of occupational and social functioning. So patient is having excessive of those symptoms, but since they are not very severe, sometimes patients, functioning may at times improve or increase. So patient may do certain things which he has left for quite some time back. So pending work he may finish, but again, it is an abnormal state. So this impairment of functioning is not very severe. So what is the duration? For 2 weeks was for depression, 1 week for mania. Duration is 4 days for hypomania. Please remember, in hypomania, you will not have flight of ideas. So flight of ideas will be seen in mania. Also in hypomania, you will not have psychotic symptoms. If psychotic symptoms have developed now, so it will be mania with psychotic symptoms. In hypomania, we don't get psychotic symptoms. Then mixed episode is when both manic and depressive symptoms, as we discussed, in a day they may fluctuate, or few days they may have manic symptoms, few days may have depressive symptoms. If it is present for duration for at least 7 days, it is a mixed episode. What is rapid cycling? As the name suggests, rapid. The symptoms: patient with bipolar disorder having 4 or more episodes of mania, hypomania or depression in at least 1 year. So rapidly the symptoms are going up and down. So this is rapid cycling bipolar disorder. So if you see this graph, the red line shows 1 year duration. So if you see 1 year, there are at least 4 episodes are there. So this is rapid cycling bipolar disorder, and it is seen in rapid cycling bipolar disorders, valproate may have better results. So treatment with valproate. Now, let's talk about the treatment of the bipolar disorder. Now, treatment would depend on the phase of the illness. So again, we'll talk about the acute phase in which the patient is presented to us. It may be a manic or a hypomanic or a depressive or a mixed phase, and the maintenance, that is for prophylaxis. So in the acute phase, let's talk about when the person has mania or hypomanic episode. So a person has come to us with symptoms of elated mood, there is increased energy, decreased need for sleep, talking a lot, excessive activity levels. So patient has mania or hypomanic symptoms. So what is the step 1? Now let us say this is the episode in which the patient has come to us, and let us say there is a history that the patient had few months back a depressive episode and patient was started on antidepressants. Now this patient has come to you in this state now. So if you are asked what is the first step in the management, again this is very, very important and conceptual. So what will you do? So before starting anything, first step you need to do is in such patient is you have to stop antidepressant, because antidepressants are elevating the mood, but the mood is already elevated. So you have to stop the antidepressants. Of course, if there was no antidepressant, then there is no need to stop it. Now comes what is the first line drugs. So we have 3 first line drugs for patient with mania. That is antipsychotics. So we have antipsychotics, lithium and valproate. Lithium and valproate, they are mood stabilizers. So antipsychotics like we have discussed, olanzapine, risperidone, quetiapine, aripiprazole. So these are some of the antipsychotics, okay, which we can use. So all these 3 are first line drugs. But yes, there may be certain situations where we may prefer one over the other. But otherwise, all these 3 are first line drugs. Now, when you talk about mood stabilizers, lithium is the prototypical mood stabilizer, but the onset of action of lithium takes time. It may take 1 to 3 weeks for the onset of action. Sometimes with lithium, we have to add drugs like benzodiazepine or antipsychotic or valproate. So now valproate generally has surpassed lithium in acute mania because of rapid onset of action and better tolerability. So if you have to choose out of the 2, if without, there is just one you have to choose, there are no other any, there are conditions given, then you may prefer valproate. But still let us understand. Now if you have to choose one drug, so let us say if the patient is having mania with psychotic symptoms, so then you may prefer antipsychotics. So especially with psychotic symptom, because therein you have to give antipsychotics, so you may choose even in severe, when the symptoms are very severe, then you can go with antipsychotic. And now suppose you have to choose one, nothing is given, you have to choose one drug, then again you can choose antipsychotics. Let's talk about lithium and valproate. Now valproate, again, it can cause PCOD in females of reproductive age group, so you may avoid giving it in females with reproductive age group. Again, I'm not saying you should not give, but if you have other option, then you may avoid. Also valproate, you should not give, there is a hepatic disease. Now, when we talk about lithium and valproate, if we compare them, generally it is seen that lithium may have good result if it's a euphoric mania. Euphoric mania means that the mood is cheerful, while valproate may be more useful in dysphoric mania when the mood is irritable. Also, we have discussed in rapid cycling, valproate may be better. Now, along with these drugs, we may also add benzodiazepine for some time. Okay, so benzodiazepine, because of the calming, sedating effect, that may also be added for short duration. Now, let's talk about when a female, is pregnant and she is having a manic or a hypomanic episode, then which drug will you prefer? So again, the drug which will be preferred is antipsychotic. It is the safest. It is not known to cause any teratogenic effect. If antipsychotic is not there or you cannot give, then lithium is the second drug which you may prefer. Now again, please remember, lithium also causes teratogenic effect. It causes Epstein anomaly, which is a cardiovascular defect. It's a tricuspid valve defect. The risk is low, 1:1000, but still it can cause, and if lithium is being given, then ultrasound and fetal and echocardiogram should be done in the patients. Now valproate generally should be avoided in pregnancy. So valproate should be avoided because it can cause neural tube defect and it is 1 to 4%. So folate supplementation, should be given, at least 1 month before conception, and out of the 3, one you should avoid is valproate. Now, in severe symptoms, sometimes we may have to do, take a combination like lithium and antipsychotics or valproate and antipsychotics, and even sometimes lithium and valproate may be combined. So, in severe cases, we may have to choose a combination rather than a single drug. Now, let's talk about treatment of acute depression. Okay, in bipolar, that is bipolar depression. So bipolar depression means, patient has come to us in this episode and patient had a history of a manic or a hypomanic episode. So this now becomes bipolar depression. So normally in depression we use antidepressant, but here one important concept you need to remember is don't use antidepressants alone. Because what will happen, suppose in this patient you give antidepressant, patient had a history of a mania or hypomanic episode, again there are chances that patient may switch to a manic or a hypomanic episode. So it is very important to not use antidepressant alone. So we can use drugs like lithium, lamotrigine can be given. So lamotrigine is one of the mood stabilizers which is found to be useful only in the depressive phase, not in the manic phase. And also one point about lamotrigine you can remember, it is safer than valproate, carbamazepine, and even lithium in pregnancy. So it is found to be safer than these drugs. Then Qutipin, it's again second generation antipsychotic. Lurasidone, again it's a second generation antipsychotic you can use. Then a combination which is shown to have good effects is olanzapine and fluoxetine. Fluoxetine is a SSRI and olanzapine is a second generation antipsychotic. And again, as we discussed, we can give antidepressant along with mood stabilizers. So never use antidepressants alone. So these are some of the drugs which are found to be useful. Now, let's talk about maintenance or prophylaxis. So suppose a patient has 2 or more episodes, to prevent future episodes, or sometimes it may be used after a single episode of mania if the associated risk is very, very high that there may be chances the person may develop a second episode. Then we can think of giving prophylaxis to prevent the future episode or to decrease the intensity of future episodes. So which drugs we may use? We can use lithium and valproate. Again, out of the two, you may prefer lithium for maintenance. And duration for at least 2 years we have to continue. Patient may not be having symptom. Patient is doing fine, but we are giving it as a maintenance or a prophylaxis medicine. Now, then there are some other mood disorders. Let's talk about them. First is dysthymia. So as the name said, dysthymia, again it's a depressive symptoms are there. So presence of mild depressive symptoms. Mild, I'm not saying mild depression, I'm saying mild depressive symptoms. So the symptoms are not severe enough to make a full diagnosis of depressive disorder. So you learned how to make a diagnosis of depressive disorder, but symptoms just mild. Maybe some days patient is reporting of sad mood, or some days patient is reporting of decreased interest. So mild symptoms are present, and these symptoms are present for at least 2 years continuously. That is known as dysthymia. Now please remember, in these disorders, since the symptoms are mild, the functional impairment is not severe. So patient may come with 2 years of history of days when the person is feeling sad, days when the person is feeling decreased energy. Symptoms are not fulfilling a diagnosis of a depressive episode. They are able to do their work, but the symptoms are continuously present since 2 years. Diagnosis is dysthymia. Again, treatment may be with CBT and antidepressants. Then there is cyclothymia. As the name suggests, cyclothymia, now it is a milder form of bipolar disorder. Here again, manic and depressive symptoms, they are occurring, but again they are not severe enough to make a diagnosis of mania or a hypomania or a depressive disorder. And again, symptoms are not very severe enough to cause severe impairment of functioning. So functional impairment is not severe, but since the symptoms are again continuously present for 2 years, this is cyclothymia. Now let's talk about some aspects of pregnancy and psychiatry. The first is postpartum blues or baby blues. So basically, these may occur in 30 to 75% of the women after childbirth, and onset may occur 3 to 5 days after childbirth. Okay. Now these are generally transient depressive symptoms. These are transient symptoms like sadness, there is mood lability, tearfulness, sleep disturbances, and they may last for days or maybe a week or two, and usually they are they would go on their own. So they are just transient. These symptoms, again, generally in these patients, we don't find symptoms like anhedonia or suicidal thoughts of harming the baby or guilt. These are generally not seen. These are more of severe symptoms. So these are not seen in these patients. So these are mild symptoms which occur and they generally go on their own. So no specific treatment is required other than supportive care. So this is postpartum blues. Then postpartum depression, as we discussed, in the specifier, 10 to 15% of the women after childbirth may experience, and it may usually till 4 weeks, but it may occur within 3 months of delivery. And symptoms, depressive symptoms are there. Along with this, there may be tearfulness, mood lability, and symptoms like anhedonia, guilt may often be present, and sometimes even suicidal thoughts or thoughts of harming the baby may also occur. So please remember that these of suicidal thoughts, anhedonia, these symptoms, if they develop, they're more suggesting postpartum depression rather than postpartum blues. Okay, again, treatment is required. So again, we can treat by pharmacotherapy like SSRI, and we can also give psychotherapy like CBT. So there is a drug, brexanolone, which is a FDA approved drug for this particular condition, that is postpartum depression. It's given as an IV infusion, and it is a positive allosteric modulator of GABA A receptors. So basically, brexanolone, it is a identical endogenous to the allopregnanolone, which decreases after childbirth. So basically, it's identical to this endogenous hormone. So this is found to be effective in postpartum depression. In postpartum psychosis, as the name suggests, now psychotic symptoms have developed. So it occurs in 1 to 2, per 1000 childbirth. Onset may occur within 2 to 3 weeks of delivery. Initial symptoms may be like insomnia, there may be tearfulness, mood lability may be there, but now delusions and hallucinations, they develop. And many times, they may be related with the baby. So the lady may have this delusion that the baby is dead, or this baby is not mine, or she may have hallucinations, telling her, auditory hallucination, telling her to kill the baby. So such kind of delusions and hallucination may be seen, and it's a psychiatric emergency. Again, we may use antipsychotics along with this lithium, and sometimes even we may have to add antidepressants. So after delivery, again, we can divide it like this. If there are mild symptoms of tearfulness, sadness, decreased sleep, it is blues. Anhedonia, suicidal thoughts, more of severe symptoms, so it is depression. And if delusions and hallucinations have developed, it is postpartum psychosis. Now let's talk about the next topic here is suicide. The rate of suicide in India, now according to the latest data of NCRB 2021, it is 12 per 1 lakh population. It is slightly increased. Most common method is hanging in India, followed by poisoning. And psychiatric disorder with the highest risk of suicide is depressive disorder. Now, one of the most important risk factor, person is having suicidal thoughts, which is one of the most risk factors, that person may attempt suicide. It is if there is a previous suicide attempt. So one has to be very, very careful, especially, if there is a previous suicidal attempt, again, risk of another attempt may be very, very high. Another second important risk factor is presence of hopelessness. So we've discussed hopelessness is negative views of the future. So if such thoughts are there, again, one has to be very, very careful. Then other risk factors like male has more, risk than females in completed suicide, because males may use more lethal methods. Then age more than 45 years. Nowadays, even in the youth also, the risk is increasing. Signals, there of suicide intent are there. For example, person has written a suicide note. Again, high risk of suicide. Then person is divorced, separated, or single. So these are again increased risk, and marriage is one of the protective factors. Like then person who is unemployed, someone having some chronic illness, delusions, hallucination. Sometimes person reported that he attempted suicide because he was hearing a voice telling him to jump. So such command hallucinations may be seen. Then substance abuse, again, is a risk factor. Poor social support, there is a history of sexual abuse, again, it is a risk factor. There is a family history of suicide, again, it's a risk factor. So these are some of the other risk factors. Next is paradoxical suicide. So what is paradoxical? The paradox word means that something which should not occur is happening. That is the paradox. Okay. Now what is paradoxical suicide? So what happens here is, in the initial stages of treatment or recovery, let us say someone is having depression and suicidal thoughts, but the person did not attempt suicide. She was started on treatment and was in the initial stage of recovery. Then the person attempted a suicide. So that is the paradox. When the person was not getting treated, she did not attempt. But when the person was getting treated, the person attempted. Why this is occurring is because of gain of energy. So person, may say or tell you that, when the person was having depression, was not, treated, the person didn't have even the energy to attempt suicide. But when the treatment was started, the thoughts were still there. So the person attempted because of gain of energy. So one has to be very careful, especially in the initial part of the treatment. Then there's something known as parasuicide or parasuicidal behavior. These are self-injurious, behaviors, but no intention to kill self. Maybe wrist latching may be there. So such behaviors may be seen.